hypertension, cardiovascular, anti-infective antibiotics. We do vaccines, and we also do thrombosis. So we cover, of course, the African aspect, the English-speaking aspect, and we are glad here today to have a robust mixture of attendees from the online audience and from the physical audience. And we also have, we are pleased to have very, very interesting presenters today. We have Florence Kamau, who will present very interesting things about vaccine hesitancy. The other day, we were being told that there are not such diseases that, despite vaccination, these diseases should be in our history books and our medical books, but they are coming back. We are proud to have Dr. Jane Martin. She'll talk about meningitis, and one of the challenges we face with meningitis is that we are getting cases of meningitis despite vaccination being there. So we don't know how we'll tackle this new problem. Maybe she'll give us an insight into that. I don't want to present for her. We're also glad to have Dr. Catherine Wendell. She's a hematologist and oncologist. She's going to present a very interesting topic, which we get a lot of questions from our Sanofi portal. And one of the interesting questions we usually get is, especially from the nursing team, is that I have this patient who has cancer. How do I vaccinate, right? Yesterday, we were at Aga Khan Critical Care Congress, and there was a very interesting question. How do we vaccinate patients in ICU? No one knew the answer. Yeah, it's very important, by the way, because you might assume that you understand and know until you come to that session and you realize the patient in ICU could be having liver failure. And if a patient has liver failure in ICU, right, and it's hit with hepatitis B, the liver dies immediately. The interesting thing is that hepatitis D can only exist in infections with hepatitis B. So those are some of the things, if you don't attend some of these sessions, you're gonna miss, right? And you realize you have a vaccine for hepatitis B, right? So many patients are succumbing, and then they realize that the patient was actually killed with hepatitis D, not B, right? So it's very interesting that the special groups are a very small number of patients, but their needs need to be catered for. We'll also have Dr. Masharia, and she will present on very interesting cases she sees in Kenyatta. And without further ado, we want to make sure that our online audience is able to hear us. We have quite a number of them online. And any of the online audience, you're welcome to ask a question. This is an interactive session, it's not a classroom session. So if you have a burning question on vaccination, in your vaccination center, whether you have I wouldn't say this or a child or someone who has undergone a vaccination, what are the questions? There are vaccinations that are happening for, guys who are going for Hajj, pilgrimage, military, places where they're going to be really congested, high schools, campuses. What do you do, right? And lastly, we want to mention that, remember, the Q&A session is open. Please ask. We have our experts here to take your questions. Feel free. It's going to be a session that is going to be really rewarding. It's going to be from 9 to 1. And please feel free to, during the breaks, take a small break and then continue. So without further ado, I want to introduce our first speaker today. This is Dr. Jane Martin. And clap for her. Thank you.
Thank you very much, Dr. Moy, for the presentation. As you said, my name is Dr. Jane Martin. I'm a pediatrician at MP Shah Hospital. And thank you so much for joining us for this session and also for the online audience. I hope it's going to be a learning experience for all of us. So I will be taking us through presentation on meningitis, specifically meningococcal meningitis, the role for the vaccine, and then finally, we are going to talk about universal health coverage, what that means in terms of vaccination, and how we optimize accessibility of vaccination with universal health coverage. Karibuni. So to start us off, we'll just do a brief overview of what meningococcal meningitis is. I don't know how many of you have had an interaction with a patient diagnosed with meningitis. Anyone? Dr. Kathy? Yeah? A lot of you have managed or been able to experience a patient with meningococcal meningitis. So meningitis is an inflammation of the lining of the brain and the spinal cord, basically what we call the meninges. You can get meningitis, bacterial infection, parasitic infection, fungal infection, viral infections, and in majority of the cases, meningitis tends to be a fatal diagnosis. If we're talking about meningococcal meningitis, this is a bacterial form of meningitis, and it is the global burden is highest in the meningitis belt. Does anybody know what the meningitis belt is? When we talk about the meningitis belt, where we have the largest burden of meningococcal diseases. Someone is whispering. Louder, please. Yeah. So in sub-Saharan Africa, you have countries which are called the Africa meningitis belt. And this is why here we have the highest global burden of meningitis. So this belt covers around 26 countries, stretching from Senegal in the west, Ethiopia to the east. So it goes across the sub-Saharan Africa. And you have around 30,000 cases reported every year in this area in comparison to the global, to the other countries globally. So if you look at the map, that's basically what we are describing as a meningitis belt. The areas in dark blue are considered to have the highest risk of meningococcal meningitis. In comparison to the global population in this area, we usually get pandemics every 5 to 12 years, and you have an incidence of 1,000 per 100,000 population in comparison with the rest of the countries or the continents, where you have an incident of 0.1 to 2.4 per 100,000. So you can see the kind of burden that we have for meningococcal meningitis in the meningitis belt. So in terms of epidemiology, who gets affected with the meningococcal meningitis disease? So outside the belt, it's more common in the older population. People who are above the age of 60 to 80 years have the highest rates of this disease. However, in the meningitis belt, it seems to affect the younger population below 30 years, and in adolescents between the age of 5 to 15 have a higher incidence of meningitis in comparison to countries out of the meningitis belt. Again, the people who are also affected are travelers, unvaccinated travelers who are coming to the meningitis belt. So, like Dr. Maya rightly mentioned, we have a lot of travelers making the pilgrimage for Hajj to Saudi Arabia. So now the Kingdom of Saudi Arabia has made it mandatory for these travelers to be vaccinated against meningococcal meningitis. So that's one of the categories that are at high risk. Other categories where you get high rates of infection are areas which are highly populated. So you have the army barracks, you have boarding schools. So areas where you have risk of overcrowding is where you have a risk of patients catching meningococcal meningitis. So these are the high-risk groups that we'll be looking at when we're talking about who are the people we are targeting for vaccination against this disease. So quickly through the transmission, how does one catch an infection with meningococcal meningitis? So droplet transmission, you can catch it by being in close proximity. Someone who has the infection or is a carrier, symptomatic or asymptomatic. And this is through respiratory secretions, coughing, sneezing, kissing. So close proximity and then droplet transmission. which is why when we're talking about the army barracks, overcrowding in schools, when you're going for a place like a pilgrimage, you have a large number of travelers in one specific area. So these are some of the risk factors, because then transmission is very easy. So asymptomatic carriage is transient and usually affects 5 to 10% of the population at any one time. So historically, outbreaks in the meningitis belt have been predominantly through the meningococcal A serotype. There are 6 known serotypes of the meningococcal disease: A, B, C, W, X, and Y. In the meningitis belt, meningococcal A has been responsible for a lot of the epidemics. So in 2010, there was a conjugate vaccine that was introduced in response to the epidemics, meningitis epidemics in the meningitis belt. And within 3 years of introducing the conjugate vaccine, there was a 98% drop in the prevalence of meningococcal meningitis in the meningitis belt. So we'll talk further about the progression of the vaccines since the introduction of the meningococcal A conjugate vaccine in 2010. Clinical presentation. So how does a patient with meningitis present? What are the most common symptoms you see in a patient with meningitis? Anyone? Headache, neck stiffness, fevers, vomiting, photophobia, irritation and sensitivity to light. Sorry? Canning sign, Canning is positive. And if I have a 2-month-old, irritability, seizures, persistent fevers, poor feeding. So these are some things to keep in mind. So the main presentations, like you said, headache, fever, neck stiffness, vomiting, photophobia, nausea. When it comes to infants and neonates, you may have very non-specific symptoms. Most of them present with what looks like sepsis. So you might just have a child who's very irritable. They might be having seizures. They're not feeding very well. So remember, for younger babies, they won't always present with this presentation. So there has to be a high index of suspicion. So approximately 30% of the people who get meningococcal disease will present with meningococcal sepsis, also called meningococcemia. How does this look like? So again, abrupt onset of fever. Patients might present with chills, diarrhea, rash. So again, you can see how this overlaps with other diseases. If a patient comes to you with a fever, chills, I'm probably thinking patient may be having malaria. Yeah. So there needs to be a high index of suspicion for these patients to help with the diagnosis of meningitis. It needs to be at the top of our minds that this is one of the diagnoses we could be tackling. On the extreme end, with patients with meningococcal sepsis, some of them may come with hypotension, especially in the older age group, acute adrenal hemorrhage, and multi-organ failure. So like we said, fatality for this disease is quite high, so it needs to be treated as a medical emergency. So in older age groups, like we said, especially outside of the meningitis belt, you might have a lot of them presenting with a bacterial pneumonia. So patients who are also presenting with respiratory symptoms, you need to have a high index of suspicion and diagnose appropriately. We've mentioned about the non-specific symptoms, which you'll see in the children who are below 2 years. So again, high index of suspicion will help with that. How do we diagnose meningitis? What tests do we request for? You've examined the patient, you suspect they're having meningitis. What next? What do we ask the lab for? What samples are you collecting? I'm just hearing whispers.
Good morning.
Good morning.
Lumbar puncture.
Lumbar puncture. What test are you requesting for when you collect the CSF with the lumbar puncture?
Microscopy.
Microscopy.
Chemistry.
Biochemistry. Then culture and sensitivity as well, yeah? Which other tests can you get? Which other sample are you collecting? Blood sample, maybe? What are we looking for in the blood sample? Blood culture, sensitivity. Remember, again, we said a lot of the patients will present with a septicemia. Yeah, so you also want to collect your blood sample, ask for blood culture sensitivity, same as your CSF analysis. Why is it important for us to do the blood culture and sensitivity? Why not just start on antibiotics?
Morning.
Morning.
Okay, to differentiate between viral and bacterial.
That's one, differentiate between whether it's a viral or bacterial meningitis. Again, that will advise on how we manage the patient. What else? There. Sensitivity to which antibiotic? Again, we want to make sure that we are treating the right organism with the most appropriate antibiotic. Is meningitis the only, is Neisseria meningitis the only cause of meningitis that we know? Yeah, what are the causes? Strep in younger children, GBS. What else can cause meningitis? Chlamydia. We also said funguses, parasites, viruses can also be causes of meningitis. So the reason why you want to get a culture and sensitivity, we want to be sure what organism are we dealing with and which antibiotic is best served to treat the patient accordingly. So as fast as possible, you want to collect the samples without too much delay. There are some incidences where you might not be able to collect the sample immediately. Some of the situations you might want to do imaging before you collect your CSF samples. So in case you have a patient who's presenting with meningitis, other differential diagnoses, depending on their signs, could be a space-occupying lesion. So you might want to do your imaging before you collect your CSF samples. In that case, once you collect the CSF sample and your blood cultures, you want to start on a broad spectrum antibiotic. How long do cultures take before we get our results? 48 to 72 hours. So we are not going to wait for 48 hours to say, I'm waiting for my cultures before I start antibiotics. Start on broad spectrum antibiotics, adjust accordingly based on your sensitivity results. So what are the antibiotics we are looking at, especially if you're suspecting bacterial meningitis? Sorry, my pointer doesn't seem to be working. All right. So what antibiotics are we looking at for bacterial meningitis? Cephalosporins. Any role for penicillins? So historically, there has been a role for penicillins, but now we are seeing more and more resistance to penicillins when it comes to bacterial meningitis. So currently our first line, third generation cephalosporins. Which one was common? Come on, say it loudly, we all know it. Ceftriaxone. This one is the one that is readily available. So again, once you take your samples, suspecting patient has meningitis based on your clinical diagnosis, start the patient on a third generation cephalosporin, adjust accordingly depending on your cultures. In the meningitis belt, we actually advise on chemoprophylaxis for close contacts. Remember what we said about the transmission? Transmission is through respiratory secretions with close contact. The reason why you want to do an antibiotic prophylaxis for someone who has for close contacts or someone who's been diagnosed is to reduce the risk of transmission. So especially in the meningitis belt, where epidemics are pretty high, you actually want to put the close contacts on antibiotic prophylaxis. So let's talk about vaccination, and specifically meningitis vaccination. Any questions so far? All right. So when we talk about meningitis vaccines, there are various meningitis vaccines available. We've talked about the 2010 introduction of the meningococcal A conjugate vaccine. to help with the fighting of outbreaks and epidemics in the meningitis belt. We also have vaccines available for routine immunization, and we're going to look at the various vaccines available for meningitis. We talked about the serogroups for Neisseria meningitis, which are most common for causing meningococcal meningitis in the world. That's A, B, C, W, X, and Y. This is important because meningitis vaccines are based on the serogroups. So you'll see we have monovalent vaccines, we have bivalent vaccines, quadrivalent. So depending on which serogroup the vaccine is covering. We also have conjugate vaccine, polysaccharide vaccines. So we'll go through an overview of the difference between the vaccines and why it's important to know what type of vaccine is being administered to the patient. So polysaccharide meningitis vaccines. Right. So polysaccharides are the outer covering of these serogroups, and you have various types of polysaccharide vaccines available to cover for meningitis. You have monovalent, meaning they're covering for one strain. So like monovalent polysaccharide vaccine against serogroup A. You have bivalent, which will protect against at least two serogroups. Currently available, you have one against serogroup A and C, and then you have quadrivalent vaccines against four of the serogroups. So they reduce the incidence of infections. They are available, for example, army bases, military recruits, and in areas where you have epidemics. So their polysaccharide vaccines are basically used, especially in response to epidemics and outbreaks. They are protective against serogroup A in infants, and C, you get about 90% protection in young adults. The problem with polysaccharide vaccines, you get very poor immunogenicity in children below the age of 2 years. So they do not have a very good protective immune response for the younger children, and the duration of the immunity or the immune response is very short. So meaning you have to keep boosting, right? So in the meningitis belt, we'll see why that is problematic. Because you see, for polysaccharide vaccines, if we're using them in response to an epidemic, it means we are chasing our tails. Yeah. The disease has already gone through the population, so we are chasing it. We are not ahead of it. It's not routine immunization. So a lot of people have already been affected by the time we are coming to manage the epidemic. So it's not boosting the health of the population. And then number two, because we've said it doesn't give much immunity for children under the age of 2 years. And for the ones where you have an effective immune reaction, it's for a very short duration. So we need to keep investing money for boosters for this vaccine. So again, economically, doesn't make sense for a place which already we are struggling in terms of low-income countries, especially in the African continent. So we said used to control outbreaks, countries with limited resources, but you've seen the downside. Even with our limited resources, it is not very wise for us to keep chasing outbreaks and giving boosters, whereas we can consider other options, and we'll talk about the conjugate vaccines. So for this reason, polysaccharide vaccines are usually administered to people above the age of 2, and usually you'll need a booster every 3 to 5 years, especially for people who are at continued risk. So if you live in the meningitis belt, if you are traveling to the meningitis belt, or healthcare workers who are at higher risk, they would need a booster every 3 to 5 years. So let's talk about a conjugate meningitis vaccine. Conjugation basically means you take the polysaccharide vaccine, you chemically conjugate it with a carrier protein. So this helps in giving a more robust immune reaction and for a longer duration of time. It is appropriate for the use of children below 2 years. And the current conjugate vaccines are available. You have vaccines against serogroup A, C, W, and Y. These ones are licensed and they are currently available. They are safe, immunogenic, and are anticipated to provide long-term protection, including children below the age of 2. So this is an added advantage for why we need to prioritize the conjugate vaccines. The other thing that I forgot to mention is something called herd immunity. What is herd immunity? Anyone? In your own words. What do you understand by herd immunity?
Hello,
Hi.
I can try. So, herd immunity, it's immunity acquired by virtue of majority of the population being vaccinated. So those not vaccinated are covered.
Very true. So herd immunity is if you have majority of the population fully vaccinated, this protects the unvaccinated people in the population by virtue of reduced transmission. So conjugate vaccines actually have lead to decreased coverage of the bacteria by about 66%. And in that regard, they reduce transmission of the pathogen. So you have reduced person-to-person transmission, conferring herd immunity for your population. So this is just to highlight the differences we talked about in terms of the polysaccharide and the conjugate vaccine. So when we talk about routine immunization, do we currently have meningitis as a routine immunization in Kenya? You sure? So yeah, meningitis is currently not part of our KP immunization program for children. However, the conjugate vaccine is actually available for vaccination. And we'll see according to the schedule when it is recommended. But the Advisory Committee on Immunization Practices recommends routine immunization of the quadrivalent conjugate vaccine for people below the age of 11 to 18 with a booster at 16 years. The quadrivalent vaccine has also been approved for immunization of children below the age of 2 years. So some of the side effects, where do we give the meningitis vaccine? Anyone knows? Administration? I know it's not routinely given, but I'm sure some of you have experienced the conjugate vaccine.
Hello.
Hello?
Where intramuscular injection on the
Yes, intramuscular injection, anterolateral part of the thigh. So these are some of the side effects that you can expect when it comes to the meningitis vaccine. Majority of them we know you get a bit of soreness, redness on the injection site. It might reduce mobility of the limb in some cases. In severe situations, you might have high fevers, chills, joint pain, rashes, seizures. But again, these are the minimal side effects. Majority of the side effects are the ones that we expect, especially on the injection site. So when you're vaccinating a patient, this is something to keep in mind. So this is what I was talking about, the quadrivalent conjugate vaccine. There is one available and has been licensed for administration from 9 months to 23 months, 2 doses, 12 weeks apart. So that's 3 months apart. So I believe those who have experienced it in the center that I work in, we give the first dose at 10 months. And then after 3 months, we give the conjugate vaccine available that is also licensed for children under the age of 2. So before we talk about this, so why are we still having outbreaks of meningitis? And we have seen that there is a vaccine available, a conjugate vaccine available that can even be used for children below the age of 2. What are the challenges? Why aren't we vaccinating all the children in Kenya against meningitis? The way we've done with polio and BCG, influenza, Haemophilus influenza. Whispers. Hazard again. I'm sure you all know why it's not in the EPI program. Affordability. Remember we said we're in Africa, low-income countries. I'm sure a lot of you guys have done to experience the meningitis vaccine. What is the ballpark figure for this vaccine? The meningitis? Let's shout a figure. Someone is whispering it over there. What is the ballpark figure for this vaccine? For the centers where it is available? 8,000 shillings. Round about, that is a ballpark figure. Yeah? 1 dose. You said you need at least how many doses? 2 doses. How many Kenyans are going to afford to give 8,000 shillings, 16,000 for 2 doses to get this vaccine? So affordability is a big problem. And these are some of the things we're going to look at on how to trickle down these vaccines to the grassroots to avoid these outbreaks. In the center that I work in, the schedule that is there includes the meningitis conjugate vaccine. So when patients get to 9 months, which is where majority of the HEPI vaccines, by 9 months, they're ending, obviously not including a HPV vaccine. Parents come and ask, so Daktari, this meningitis vaccine at 9 months, is it important? What do you tell the patient? Very important. And then what do you tell them after that? It is very difficult to manage this disease and the vaccinations will help. What else do you tell her after that? We have the vaccine available in our center and it is 8,000 shillings out of pocket. So you see the challenges we have. You tell them, yes, it's very important. You even tell them about meningitis and the side effects of meningitis. Then you tell her, but you need 16,000 shillings to vaccinate your child. You see the problem? And this is an out-of-pocket payment. So these are some of the challenges we're having when it comes to integrating something like the meningitis vaccine into our child vaccination series. There is some good news, however. There is a new vaccine coming in. This is in collaboration with PATH and Serum Institute of India to help the meningitis belt. They want to introduce a conjugate multivalent vaccine that covers against 5 serogroups. So the aim for this vaccine, one is affordability. In comparison to what we currently have in the market, they need to look at affordability and accessibility. All right, so this needs to get to the low-income countries, especially in the meningitis belt. So we are hoping that is a step closer to us being, to us achieving a meningitis-free continent. So in terms of immunization for travelers, we've talked about the recommendations. We recommend that travelers above the age of 2 months who either reside in the meningitis belt, are traveling to the meningitis belt, should be vaccinated with a quadrivalent conjugate vaccine before travel. Remember I mentioned for Saudi Arabia, they've made it mandatory. So anyone wishing to travel for Hajj needs to show vaccination status 10 days prior to arriving in Saudi Arabia. For children who have received a vaccine before the age of 7 years, they need a booster after 3 years, and after that, every 5 years. For those above the age of 7 years who received the initial vaccine, you give a booster every 5 years. So those are some of the recommendations for travelers. In Kenya, are we in the meningitis belt? Yeah? There are certain sections of the country which are actually on the meningitis belt. So in 2019, as part of the campaign to try and manage outbreaks of the meningococcal meningitis, we had a campaign carried out in Lodwar Referral Hospital, and this was targeting counties in Turkana, Marsabit, Mandera, West Pokot, and Wajir, because this is in the northwestern region of the country, which borders South Sudan, Ethiopia, and Uganda. And remember when we said the 26 countries involved to the east, South Sudan and Ethiopia. So these areas are considered high-risk areas for meningitis outbreaks, and this is why we had mass campaign to try and manage the outbreaks. Hopefully, according to the National Immunization Policy Guidelines in Kenya, we are hoping to introduce meningococcal meningitis as part of the child immunization program in the next 1 to 5 years. So we wait to see. Please ask me a question. Please. Okay, learn something. There's a question back in.
Yes, I just wanted to ask, is neck stiffness one of the cardinal signs that you look for very if a child is presenting with meningitis?
So yes, neck stiffness, especially in older children and adults, is one of the signs that you look at for in meningitis.
Cardinal.
Yes. However, again, like we said, you might have other causes of neck stiffness, so it needs to be together with other associated symptoms, fever, altered level of consciousness, because neck stiffness alone is not enough to say this is a patient who has meningitis. Other causes of neck stiffness? Sorry? Bad posture. Bad posture. Tetanus, neck mass. So yes, meningitis is one of the cardinal symptoms that you look out for, but it has to be together with your other symptoms. Fever. And remember, when said under 2, you might not get some of these cardinal symptoms like neck stiffness. So mainly looking out for features of sepsis.
My question is, let's say there's a child who had meningitis and they didn't get the vaccine, and then maybe we become okay, you give the vaccine.
So the question is, you have a child who gets meningitis, they are treated, they recover. Do they get the vaccine? Yes, no? Yes, no?
Yes, I think we should, because we should consider treatment first. Having gotten a baby before and not have to be protected in the future. And B, you might have gotten meningitis from, let's say, it's bacteria from one cell. So you need to take the rest of the cell. So I think once you heal, you get the vaccine.
Thank you, man. Yeah, so exactly what you said, you have different strains of the disease. So you may have gotten an infection from one of the strains and you fully recover. But the reason why we are advocating for what we call the quadrivalent is you want coverage against different strains. So even when people ask you, when I get the meningitis vaccine, does that mean I'm never going to get meningitis again? Same thing. It depends on the strains you've been vaccinated against. And every day we're getting new strains of diseases coming up. So you have to inform them. It doesn't mean you're never going to catch meningitis again. It gives you a certain amount of protection or immunity against these serotypes. But as the rest keep coming up and the vaccine developments continue, we still want to do boosters to make sure that you have continued protection against all the serogroups.
It's a question. I would think, can you repeat that schedule for the travelers? Thank you.
Correct. So immunization for travelers. So again, for people who are traveling to the meningitis site or areas of high risk, people who live in the meningitis belt or people who will be there for a prolonged period of time, the vaccine is recommended. Here we go. The vaccine, quadrivalent conjugate vaccine is recommended, especially for people around the age of 11 to 18. And then you have a booster for 16 and 16 years. If the children who receive the vaccine below the age of 7 years, they will need a booster in 3 years' time. And then from there, every 5 years. If you have the children above the age of 7 who received the vaccine, they will need a booster every 5 years. Does that make sense?
Hi, Doc. There's a related question here. If your child was not vaccinated and is now 3 years, can they receive the vaccine and how many doses will be required?
Right. So again, if we look at this vaccine, the child is 3 years and they didn't receive the vaccine, yes, they can still receive the vaccine. The dosing, I think, is 2 doses, 1 dose, yeah? Yeah, above 2 years, 1 dosing of the vaccine. Below 2 years is when we give 2 doses.
There's another question. Thank you for the presentation. Is a meningococcal vaccine safe in pregnancy?
I think I want that over to be.
So, unfortunately, we not conduct studies when it comes to the safety of the vaccine in pregnancy, any vaccine, but unless they basically have for incidental, finding, okay? So the vaccine is registered or it is being licensed to be given from 9 months up to the age of 55 years. However, if you give it in pregnancy, that one is now, we call it becomes a pharmacovigilance issue. So you need to report so that you follow up on this client. That's how from our end. The vaccine is not to be given in pregnancy. We have no data to show the safety of this vaccine in pregnancy. Okay.
So we have another question here. So immunity is conferred against the strains that you've been immunized only. So maybe I think one question we usually get is when I'm in the States, itadungwa gani? So which one will I be given? So I think it's the same question, and then which strains are you covered against based on the vaccine? And then a second question is if you can buy clothes in advance, why can't you buy the vaccine in advance?
save for the vaccine in advance.
All right. So in terms of the strains that you're covered against, remember we said there are 6 strains of the Neisseria meningitis, which cause the disease. The current conjugate vaccine available covers against 4 quadrivalent. So it covers against serogroup A, C, W, and Y. I believe again, this has also been licensed in the States. So it should be the same strains that you're covered are. Like I mentioned, with the new research coming up from WHO and the Serum Institute of India, they are looking to have 5 strains covered to introduce in the meningitis belt. So you'll have an addition of the B. On top of the quadrivalent, the additional serogroup that will be included in the 5 strains will be B. But again, this hasn't been rolled out. I think Nigeria is the only country that has started to roll out the new vaccine by the World Health Organization to see if it will help with epidemics in the meningitis belt. So if you're getting the quadrivalent conjugate, I believe it is the same that you're going to get in the States and in Europe. Yeah. Someone said about if you can save for clothes or your baby, you can save for vaccines. I'm going to talk about that in my next presentation as parts of coverage for universal health coverage. So we'll talk about that and what our role in that is. All right. So if you'll allow me, I will go through my next presentation, which is achieving vaccine coverage with universal healthcare. You guys have all heard our president talking about universal healthcare. What's universal healthcare? What do we mean? Okay. Chief. One heard of SHIF. Chief. Yeah, some of us are not very happy about it. What do we understand by universal healthcare or universal health coverage? I'm sure you guys know something. It is universal healthcare.
It's affordable,
Mhm.
affordable and available, accessible by everyone in the community.
Fantastic. It's basically that, yeah? So we're trying to get the highest quality of healthcare, which is affordable, which is available, ideally at community level. So when we look at universal healthcare, it aims to make sure Kenyans have access to the highest quality of health without suffering financial hardship. Remember what we talked about out-of-pocket payments. So those are some of the things we're trying to tackle with universal healthcare. So these services that are being offered with universal healthcare, you want to promote good health, you want to prevent illnesses, you want to help cure the people who already have illnesses, and also to support the people who are undergoing rehabilitative and palliative services. So universal healthcare is not just for vaccines. It is not just for people with diabetes. It is just not for road traffic accident victims who need rehabilitation. It should be accessible to all Kenyans, and it should provide all these services. So universal healthcare is crucial in addressing our burden of communicable and non-communicable diseases. So out-of-pocket payments are digging our citizens into catastrophic health expenditures. So you can imagine, like you said, your child or someone's child gets meningitis. You get admitted into the ICU. Child stays there for a month or 2. And unfortunately, they recover from the illness, but they recover with disabilities. Yeah. So let's look back. If we are promoting preventative health services, if we advocate for the affordable conjugate vaccine in the meningitis belt to trickle down to the grassroots, this is a child who has access to vaccination at a very early stage. So we preempt the disease, try and prevent this child from getting meningitis in the first place, save the family the cost of having the child in the ICU and the rehabilitative services that come from the disability associated with things like meningitis. So if you look at that model, what have I just described? What model have I just described to help us in upscaling universal health coverage? What is it called? You guys have heard of primary health care. What's primary health care? What do you understand by primary health care?
Primary health care and based on promotive and preventive care. Promotive, preventive care. Where does primary health care occur? In the community. Yeah, it starts at the community. So it's easily accessible.
Patient-driven. So the patients in Lodwar do not have to come to Nairobi to access the vaccination for their children. They will be readily available in the communities. So the model that we're looking at to upscale universal health coverage. So one, you want to expand the population that is covered by the healthcare services, especially in the underserved and the marginalized population. So there is equity of access. The same vaccines that we are accessing in Nairobi County, Marsabit have them as well, Coast Region have them as well, Rift Valley have them as well. So equity means that these services are made available to every Kenyan at a household or community level. Expansion of the health benefits that are reaching the Kenyans. So we've talked about promotive, so when it comes to promoting health services, and this is where we'll talk about education for the citizens on why it is important to have some of these services. Someone said, we are very happy to save for clothes for our children, but meningitis vaccine is where we draw the line. But do they know the importance? Have we talked on a community level about the importance of vaccination? Have you gone to your church groups and your chama and asked them, have your children gotten the meningitis vaccine? Why? But you have 8,000 shillings to use for something else. So education as part of promoting health services. And then establishment of financial risk protection. So yes, these services are available, but not to a point where you have to take your money out of pocket to access these services. So basically, those are the dimensions we talked about. Which services are being covered? Who is accessing these services? And what is the financial protection for the citizens to access these services? So in describing the primary health care network, we've said that you want to be inclusive, equitable, cost-effective, and an efficient approach to enhancing the physical and mental health of the citizens. So these are some of the elements of primary health care. You want to educate the people on why it is important to vaccinate your children, to vaccinate the older age group. Prevention and control of locally endemic diseases, provision of essential drugs, maternal and child health care, including family planning services, expanded immunization against major infectious diseases. We've covered that quite a bit. Promotion of food supply and proper nutrition. Remember we said universal health coverage, we're also trying to tackle communicable and non-communicable diseases. So when it comes to promotion of food supply and proper nutrition, we're looking about at lifestyle diseases, obesity, diabetes, hypertension, appropriate treatment of common diseases and injuries. You don't have to have a patient traveling from one county to the other to go and have an MRI done because they had a trauma. So again, this needs to be available at community level. Adequate supply of safe water and basic sanitation. We have less diarrheal diseases, and therefore we are protecting our citizens from getting some of these communicable diseases. How do we implement the primary healthcare model? So number one, we need to have the manpower. Who are the main people who are the drivers of the primary health care model on the grassroots? We said it's at a community level. So who are the main people who are going to be there? Community health promoters, community health workers. These are the people who know what kind of community they come from, what are the reservations amongst the people in the community. You come to places where people come to the hospital and you try and give them a blood transfusion and they say no, right? So community health workers have a pulse into what the community needs and how to best approach it. Again, we've had situations where you run campaigns for vaccination, for preventative services such as malaria and mosquito nets, and you go and come with a whole bag of mosquito nets and they refuse to take them. Because we need to understand the community approach, and the people who help us with that are community health workers. These are people we need to invest in to ensure that we have proper service delivery at community level. So investment in prevention and health promotive initiatives. So this is what we're talking about. Number one, we need to educate the communities. It's not enough for us to say we have a meningitis vaccine, please come and take it. We have a rise of anti-vaxxers. Why do we have a lot of people who are now saying, no, I don't want my child vaccinated? You also have community levels which don't believe in vaccination. We haven't properly educated them. There are also news going around vaccination causes developmental delays, autism. My child got the vaccination, they ended up in ICU, they died. I'm sure you've heard all this kind of messaging. So while there is a rise of all these myths and negative messaging against vaccination, we as healthcare providers need to be louder in terms of promoting why vaccinations are important and demystifying some of these myths, right? I believe majority of us here growing up received quite a few vaccinations. If this case was true, because developmental delays, I would imagine quite a number of us would be having some form of delay. So it is important for us to provide accurate information at a grassroots level. So when the mom is pregnant, I don't wait for 10 months to say, oh, you've gotten your measles vaccine now next month. We need 9,000 shillings for you to come for meningitis. Have the conversation from antenatal clinic. Talk to her about vaccinations. Do you know about the vaccinations that the government provides? There is a vaccination against meningitis that is available at 10 months. Currently, it's not available in the government, but there are centers which have it available at a certain cost. Hopefully, when we get it in the guidelines, then they will be a bit more open to receiving the vaccine because they've had this information before. It's not a new concept that you're introducing. So educating individuals and communities helps to counteract the social cultural barriers. And we're in Africa, the myths are many, especially when it comes to vaccination and diseases and all that, there are many. So it's our role to demystify some of these barriers. Empower individuals and families to optimize their health by ensuring and promoting health surveillance and response to disease threats. So if you're having flooding in certain areas, talk to people in that community about the expected health outcomes. We expect that because of flooding and poor drainage, you may be having diarrheal diseases. How as a community do you protect yourself? How do you protect your children? So it's important for us to educate and empower them. What do we need to do to promote their health? And then strengthen integrated information systems for primary healthcare information sharing And this helps in decision-making for health interventions. So when you have integrated information systems, we're able to do surveillance of the most vulnerable groups, for example, who require vaccinations, who require boosters. We're able to track this kind of information. We are also able to come up with systems of effective distribution of vaccines to these marginalized and underserved communities. We know vaccines, our biggest issue is cold chain. How do we maintain this cold chain in underserved communities? Do they have to come to the major hospitals for them to access the vaccines? In some of these areas, you don't have road networks, which allow you to administer the vaccine. So if we have integrated systems and we do surveillance on these underserved groups, then we come up with solutions on how to get, for example, the vaccines to these kind of people. During the COVID vaccine, I don't know whether you guys heard about some areas where vaccines were being delivered by drones. Has anyone heard of that? So you had certain areas where you don't have road networks. So the governments were able to deliver vaccine through drones. You identify that there are certain populations in very remote areas, and you come up with solutions that work for them. So these are the kind of models that we are looking towards. How do we trickle down these services to even the most remote areas in our country? Sustainable access to vaccines. So in the African continent, there have been quite a few inadequacies in administering of vaccines, especially in the under fives. About 30 million children under 5 suffer from vaccine preventable diseases, which account for about 58% of the global vaccine preventable deaths. So again, we still have a long way to go in terms of vaccination in Africa. How do we sustain access to vaccines? The COVID vaccine actually highlighted that our primary healthcare model is the weakest link. Because if you currently go to the remote areas, how many of the people in the grassroots do you think received the COVID-19 vaccine? In comparison to like the more high-income counties, the cities, Nairobi, Kisumu, Mombasa. So there was a huge discrepancy, especially in the vaccines between the high-income areas and the low-income areas. So this was a big weakness that was revealed during the COVID vaccines. The other thing that the COVID pandemic highlighted is that we had disruption of services. Patients didn't want to come to the hospital to get their children vaccinated. Why? Our children are going to catch COVID. I remember we actually had to separate the services and again, educate our patients and tell them these are the precautions we've taken. You need to bring in your children. Even in the height of a pandemic, we need to continue with the routine vaccinations. So this, in 2021, about 25 million children in Africa under 5 missed out on their routine immunization. You can see how far back that takes us. Now we have missed vaccines. We need to do catch-up immunization because there wasn't proper education on our patients on what they're supposed to do in terms of routine immunization in the wake of a pandemic. So when we talk about sustainable access to vaccinations, Africa holds about 10% of the global share in the public market sale of vaccines, yet we have a demand of about 25% the global vaccine. So what do our governments need to do to help us have sustainable access to vaccination? We're hoping to get here one day where we can produce our own vaccines. What were we doing during COVID? We were waiting for foreign countries to bring for us vaccination. So hopefully in the future, we can have technological capacity to have our own vaccines and other medical supplies. So we need the government to support in terms of infrastructure. We need proper electrical supply to be able to maintain our cold chain. So when we talk about universal healthcare in terms of vaccines, these are some of the solutions we are looking out for. One, enhance our primary healthcare model, and two, look to educating our communities, and also technological approaches which can lead us into the future where we become self-sustainable. Any questions? Comments?
Applause. Thank you very much for your attention.
So, guys, stand up. Guys, asleep. Where were you last night? Just stand up for 1 second and clap for Dr. Jane March again. I think she's explained meningitis like a mother to a child. So you explain it to the mothers out there and their children, right? Thank you again. Can I have a seat? So we'll introduce Dr. Masharia quickly and then we'll go for a break. So she can present some very interesting things.
Good morning. Good morning, everybody. I'm sorry for coming in late. My name is Anne-Marie Masharia. I am a pediatrician. My specialty is infectious disease, and I work at Kenyatta National Hospital. So I'm involved in quite a bit of infectious disease work, be it measles, pediatric HIV, as well as other things that we will be discussing. So I'm sorry I wasn't here to just meet people, but we'll interact during the tea break, yes, as well as the lunch session. I think they've heard me. Yeah, I was loud enough. Yes, so other people online, yes, so I'm very happy to be here. I'll be there. Yes, after tea. I think this was just an informal introduction. Yes, as we break for tea. Yeah. How many people do you have on that? Is there a people? Wow, okay. Good morning. Yes, I'm Dr. Anne-Marie Masharia, pediatrician, infectious disease specialist from Kenyatta National Hospital. And I'm very happy to be here with you this morning discussing an issue close to my heart, which is immunization. Thank you. So I officially invite you for tea.
Sorry, we do the tea break at 11. Thank you so much. Yeah, let's take up here. So just come and present. So apologies for that. We'll be having Dr. Masharia present, and after that we will have the short tea break. Sorry for that. It's long. So any questions from the ground? remember you still have very experienced pediatricians here. We have a question for Dr. Martin. There is someone who is asking, do ladies who are pregnant have immunity against meningitis? That's different from can we vaccinate pregnant ladies? So tell us a bit about do pregnant ladies, even if they're vaccinated, they have any immunity against meningitis? It's a postgraduate question. She will check that out. Yeah. The other question we had. So someone is also asking, in which sites are these vaccines administered? What happens when they are administered in sites beside the recommended ones? Can they harm the patient or the small doses too small?
Sites being like the location of the vaccine to the injection. So for the younger children, we say the anterolateral thigh. In older children, you can actually do it on the deltoid. So the reason why you have specific areas is for maximum absorption of the vaccine. So adjustment of the sites away from the recommended ones might mean that you don't get an adequate dose of the vaccine, and you might not get a good immune reaction. In some situations, with wrongly, with sites that are not recommended, you may get situations where you get an abscess. So those might be some of the side effects of not using the recommended sites. Yeah.
A last question. What is the difference between immunogenicity and reactogenicity?
Immunogenicity is how do I say it? Immunogenicity is the kind of immune response that the vaccine elicits in each individual. So like when you say for polysaccharide vaccines, you don't have a very high immunogenicity in comparison to like the conjugate vaccine. Reactogenicity, this is the side effects of the vaccine. The certain side effects that we talked about, we have some patients who get a fever, fatigue, tiredness. So this is the reactogenicity, how the individual patient reacts to the specific vaccine in terms of expected side effects.
Okay, so we're introducing Dr. Anne-Marie Macharia. She'll present a bit about some of the diseases that are emerging contrary to vaccination.
It's a laptop, guys. This is the charger cable. Okay. Thank you. So good morning once again. I'm very happy to be here, and I think I particularly enjoyed these sessions where I saw that majority of our audience are nurses. Am I right? Yes, so I always tell people that my mom is a retired nurse, and she's the reason why I actually decided to pursue this profession. So nurses hold a special place in my heart, and I think my colleagues will agree with me that, especially as pediatricians, we work so closely together that if the nurse and doctor do not have a harmonious relationship, then the patient is the one who suffers. Yes, at a personal level, I'm a mom of 3 wonderful children. I have a 20-year-old youth who I'm hoping gets into medical school, a 17-year-old and a young boy of 14. So I love children, even just from that aspect. I love fitness. I love self-care. So I also just, because I think we work in a profession that's very hard. You know, my colleagues in Kenyatta, like Kathy is a pediatric oncologist. I don't even know how she does it. And then the nurses are the ones spending time with patients in very difficult situations. So I always encourage people, take time for yourselves, yeah? Apply a little lipstick, make yourself feel good. Make yourself feel good in the morning. Yes, my mom always used to tell me the first thing you do, which I think is very good for your mental health, even if you're not going anywhere, wake up, shower, change, look good, look in the mirror and tell yourself, yeah, you look good and you're going to have a good day. Yeah. So I believe we're going to have a very good session here together. And thank you, Steve, for always inviting me just to have these interactions. So if it gets too technical, too boring, stop me, because I think these are things that we all know. These are illnesses that we're dealing with all the time. So I'm hoping that it's also a bit of an interactive session. If you have any questions, then we deal with them at the end. So what I'm presenting on is first emerging diseases contra to vaccination, and then I'll be alluding to vaccine hesitancy, which you've seen is repeated in the program. Jane has talked about it. We'll have a session later, because we are the link between the patients actually getting the care we need, and yet sometimes we as healthcare workers are the ones who are the barriers, yeah, when it comes to immunization. So I just use the arrow, okay. Am I not connected? Okay, so this is going to be the outline of my presentation. We're going to define what are emerging diseases and what is an outbreak, mostly so that if it is happening in a center where I'm working, how do I recognize that there's a possible outbreak? We'll discuss a few vaccine preventable diseases and see what are our KPI targets associated with these outbreaks, focusing a little bit on polio, because despite all our efforts, it continues to be a problem. And then a bit about mumps, measles. Then we'll look at vaccine hesitancy and see how to address it. And then we'll end with a brief case presentation. And I'll try not to stand between you and lunch. Yeah. No, even tea. We've not even been given tea, Steve. Yeah. So the next slide, please. Okay, good. So what are emerging diseases? So emerging diseases can be defined as infectious diseases that have either newly appeared in a population or have existed but are rapidly increasing in incidence or geographic range. So I think the most recent example of this we have seen is COVID. Yeah, so we have known about viral illnesses, and indeed it is closely related to coronaviruses that we have known before. And then this appeared newly in the population. And over and above that, it was rapidly increasing in both incidence, meaning the number of cases that we saw, as well as the geographic range that was affected. An outbreak is defined by the CDC as 2 or more cases of the same illness, or an observed number of cases that is higher than the expected number, or having a single cause, a case of a disease caused by a significant pathogen. So if we think about 2 or more cases of the same illness, in our outpatients recently, have we been seeing more than the expected cases of some infectious diseases? Do we have some instances of that happening? Any volunteer? And remember, in adult learning, there are no wrong answers, yeah? Have we been seeing more of anything in our outpatient departments? With the changing weather patterns, the floods that we have, has anybody observed, for example, an increase in diarrheal disease? Yeah. In some places, have you been having increased positivity, for example, for rotavirus? Yeah. So we, as the healthcare workers who are recognizing these, are the ones who are supposed to raise that alarm. I remember that came up on one of our pediatric groups. And what we're actually thinking is during that period of COVID, when there was delay, and then we gave new guidelines on how rotavirus should be given. So instead of giving it to the much younger child, we were giving it to older children up to the age of 1 year, isn't it? And yet, initially, we used to say that's a vaccine that a child should not receive beyond 8 months, yeah? So what is then the effect of delayed immunization when the baby has already maybe been exposed to the viruses? And does it have as good a take, as long a duration of protection as when it was given at the right time? So when we raise those sort of alarms, that feedback enables the healthcare system then to change and adapt, to either be ready for more cases or to be even more vigilant if it comes to immunization. When you have a significant disease, like the cases we were having of Ebola, yeah, I happened to have just joined Kenyatta working in COVID when we got a suspected case of Ebola. Such a patient, that is considered an outbreak just because of that severity of disease, yeah? And we were all there very frightened. At least we had learned how to don and doff, yeah? But when that case was noticed, unfortunately, there had been exposure of some surgeons in Uganda who subsequently died of Ebola simply because the people who suspected the patient interactions already went on before an alarm was raised. So it's important as the primary healthcare worker, you're often the front line to be able to identify what constitutes an outbreak situation. So these are some of the diseases that we continue to see despite the availability of immunization, and that is poliomyelitis. We're still having measles outbreaks. We had seen cases of pertussis, and this is something that seems to come and go. We've had a resurgence of influenza, yeah? At least where I'm working, we have seen an increase in viral respiratory illness. And you know, the traditional learning is that influenza is a disease of the cold season, yeah? But now right from January, with the interesting rain patterns, with the changing temperatures, now we blame everything on global warming, yeah? Disease patterns are changing, meaning that even when you used to advise parents, for example, you need to get a flu jab, maybe you're telling them before July. Right now, you can actually just immunize that child against influenza, and being more keen to think which is the population of children that are vulnerable, who are those and may need that extra immunization. So influenza is a big one, as well as a lot of cases of tuberculosis. Maybe we're seeing more because I work at the National Hospital, but spread of tuberculosis also tells us that there's something we're not doing in terms of both infection prevention and control within the community, as well as identification and early treatment of cases. So I highlight this because when there's a sort of increase in TB cases, the people who are most affected are we as the healthcare all the time, yeah? So both for identification and for your safety as a healthcare worker. So we're going to look at polio in a bit of detail. We've all seen these pictures. We've all seen a number of our population who look like this. I think less so. If you have older relatives born in the 50s, maybe, or 60s, you must have a family member who was affected by poliomyelitis. And sometimes effective immunization makes us forget what a devastating illness polio is. So the person who is begging beside your car and is having to use crutches, and you're seeing a lot of wasting of that muscle, probably is somebody who suffered childhood polio. There's a gentleman I see sometimes as I drive around Kawangware, and I see that gentleman, he'll drag himself from where he's living in Kawangware. He comes all the way close to Kenyatta. He's barely mobile. He just uses his hands. And you think of the devastation that could have been prevented in his life by immunization. So as we start to not see these diseases anymore in the community, we particularly as healthcare workers should not forget just how important immunization is, because we are maybe no longer seeing this devastation at a large, in such a large population as we used to before. So we'll remind ourselves what polio is, and it is a severe debilitating illness caused by a poliovirus. And poliovirus comes from the Greek words polios, meaning gray, and marrow meaning, mylos meaning marrow, and itisis, we know is inflammation. And it's described that way because it tends to affect the nerve tissue, all right? So there are three types of poliovirus, and we're going into this just to understand, which we're going to come to later, why it's important for our country to transition from oral polioviruses and completely move to injectable polioviruses like they do in the West. So there are three types of wild-type poliovirus, wild-type poliovirus 1, 2, and 3. And man is the main reservoir, and it's transmitted by fecal-oral or even droplet infection. So the whole stage is about 6 months to 3 years. So the younger infant is protected by maternal antibodies, but we know that wanes almost completely by the time they're 6 months. So it's a disease of children. So wild-type poliovirus 1 was considered eradicated in 1999, and it took a couple of years before the World Health Organization could certify it as eradicated, which happened in 2015. And then wild-type poliovirus 3 was eradicated in 2012, certified in 2019. Wild-type poliovirus 1 has been eradicated in most countries, but as of 2022, still endemic in Afghanistan and Pakistan. Disease. So it will happen mostly in areas where there's also low vaccine coverage here. And IPV will protect both against associated paralytic polio as well as the vaccine-derived polio virus. So seeing that the wild type, we have 99% reduction in the wild type since 1988. Type 1, very few cases as at 2013. Issue is more this vaccine-associated paralytic polio. About 250 to 500 cases are seen globally per year, and type 2 accounts for most of it, which is why the first step was even in that trivalent oral polio virus to remove the type 2, which causes most of the VAC. And then the vaccine-derived polio virus accounts for about, type 2 again accounts 27% of the circulating vaccine-derived. So the strategic plan had 4 objectives, which was to detect and interrupt all cases of poliovirus transmission, to strengthen immunization systems, introduce the inactivated poliovirus, polio vaccine while withdrawing the oral polioviruses, contain poliovirus and certify interruption, and then we plan the legacy. So as a country, we are still in step 2. Yeah. Okay. So this is just looking at what that roadmap looked like. So before 2015, we needed to introduce at least 1 dose of injectable poliovirus into the routine immunization, which we have done. In 2016, we switched from the trivalent OPV to bivalent OPV. And as a country, we are supposed to withdraw routine OPV use and switch completely to use of injectable poliovirus. Okay, I think we've gone through that in terms of why we want to remove the OPV2, which was said causes both most of the VAC as well as the vaccine-derived polioviruses. And now the new strategic plan, because you saw that that one ended in 2018, the eradication strategy from 2022 to 2026, the first goal is to permanently interrupt all transmission in endemic countries, as well as stop the circulating vaccine-derived polioviruses transmission and prevent outbreaks. And I'll have a small case that I think demonstrates why this is still an issue. So as at 2022, we were still having outbreaks, and you can see the countries involved. And Somalia tends to be a source of our cases of polio. And I think with a large population, especially, I think if you get into Islay or some of the suburbs here, you have people coming in and even children who are presenting to hospital, and they have never been immunized because maybe they're coming from countries where vaccine systems have really broken down. So that's why that alert continues, because we did have cases at some of the refugee camps, and that was in as recent as 2022. And the surveillance that is done by KEMRI continues to occasionally identify some vaccine-derived polioviruses. And yes, you'll hear it came from the Islay area, yeah. So just to know, we still have populations that are at risk. And even for the patients who come into hospital, if they've come because of another illness, do we always ask, is this child fully immunized? Do we get those cards to actually establish that indeed they have received all the immunizations? And I think this is more important, especially post-COVID, when even just our own population here, there was a lot of interruption of immunization services. And we'll look at our scorecard and see. So in July of 2023, there were 8 cases of circulating vaccine-derived poliovirus at Hadagera refugee camp. 4 of them were genetically linked circulating polioviruses isolated from the stool samples of 2 children who presented with acute flaccid paralysis. And because of those cases, they then screened all the under 5s, and there were 2 contacts who were asymptomatic but had this poliovirus isolated. The first case was a 2-year-old male. He had actually received 3 doses of OPV. He had not traveled. The second case was a 2.7-year-old female who had received 3 doses of OPV, but she had traveled to Somalia. And the contact was asymptomatic, but he had never received any immunizations. Yeah. And then all 4 cases were genetically linked to a circulating vaccine-derived poliovirus that had been shown to be circulating in Somalia. So that's why it's important when you come across these children, take those samples, because it helps us, even as a country, know what are the potential risk areas and where is the vaccine coming from, and we're able to put public health measures in place. So before I got to that, now I'm giving people leakage. I was supposed to play a small video. Are we able to play it, Dr.? We'll play it at the end. Okay. So we're going to move on to another vaccine preventable disease that we're seeing a resurgence in, and this is pertussis, also known as whooping cough. So it's epidemiology. So annually, there are many cases worldwide, 16 million, and 95% of these happen in low-income countries, and it is still causing a significant number of annual deaths in the range of 81,400 in 2022. We've had recent large outbreaks in several high-income countries, both among infants and adults. Maybe the reason is we're able to pick it up with improved diagnostics. It could be about the pathogen adaptation. It could be about waning immunity, because if you remember, at least in our population, we only give the 6, 10, and 14 dose. Is there any other booster we do for pertussis? 18 months. And then after that, any other boosters? First of all, 18 months, do we do it on our national program? We do not. So the majority of the Kenyan children only for the 6, 10, and 14 weeks, isn't it? And then, but you can do a booster at 18 months. When else should a child receive a booster? 5 years. Any other booster? 10 years. Very good. I can see these are well-informed people. Any other boosters? Okay. How long is pertussis immunization protection thought to last? On average, a guess is allowed. How many? 5 years. Okay, maybe closer to 10 years. And why is that important? It's because we must start to think of vaccines through the life course. I heard Dr. Mate mention immunizing both adults and children. During COVID, at some point, there was a tridemic of COVID, influenza, as well as RSV. And the people who are getting into ICUs were the grandparents of these children. So when children are also not adequately immunized, another population that becomes at risk are those people who are aging systems. Yeah. So you may not have we may, as pediatricians, and people working with children may not have a lot of exposure to what is happening in adult medicine, but I attended a symposium where Dr. Muhindi, the pulmonologist, was presenting. And you're having people in their 50s and 60s who are getting into ICU with influenza. RSV is what they're finding, and COVID, yeah? So when you protect children, you're also protecting the adults in the household and vice versa. When you protect the adults, you're also protecting the children. So we're having more outbreaks, and it's thought that there is some waning immunity, as well as some theories around the acellular vaccines giving shorter lasting immunity. Those studies are not really supporting this. Even people who received, because I was a recipient of, I'm sure the what do you call it? The vaccine that's not acellular. The whole cell pertussis vaccine is what I received. And during this outbreak, which I wanted to talk about, I really got bad symptoms of pertussis. I mean, I was coughing and having to hold onto the wall. Yeah, so much so that my husband had even told me to first just go and be tested for TB. And then now I can come and interact with people in the household. So I think whether it is a wholesale or a cellular pertussis vaccine, we're beginning to recognize that concept of waning immunity and the need to have immunization programs for adults. So we are having increased prevalence of pertussis amongst adolescents and adults, and this is a public concern because the very young infants who are not yet immunized do not have good protection. So that baby who's coming in with a neonatal pneumonia, having a cough that is persistent, and they are not yet due for their 6-week vaccine, pertussis is a diagnosis that you need to keep in mind. Diagnosis in adolescents or adults may be missed because their symptoms are milder. And their new immunization strategies, what I'm talking about, the adolescent booster vaccines. Cocooning means you vaccinate everybody within the household so that before that child is due for their vaccine, they do not have people who are likely to transmit to them, as well as a lot of interest around maternal immunization, because that will boost the antibody transfer to the babies. So pertussis, I feel, is quite underestimated because even when patients present with a cough, most of the time they don't visit us. They go into a pharmacy and they get some cough syrup prescribed. We as physicians, pertussis is not a disease I think we've really been emphasizing on or even seeing very severe cases, so there's under recognition. You need fairly sophisticated and expensive tests because you need either a respiratory biomarker or a PCR to confirm diagnosis, so there's underdiagnosis. And then because we're not reporting, we may not understand the full magnitude of the problem. So there was this outbreak at one of our hospitals, and you can see the population involved: 8 years, 3 weeks, 34, 6 weeks, 45 years, 5 weeks. And unfortunately, there was a mortality of a child who was aged 8 years, and the diagnosis of pertussis had actually been confirmed on PCR. So the MOH did that outbreak survey, and they found that there were total cases, and this is the national data at that point, and there were 6 cases with 1 death, and that's quite a high case fatality rate that we discussed at that time. So transmission to young infants, the source of infection is usually household members, the parents, the siblings, the aunts, grandparents, and caregivers. In diagnosis, CDC recommends using Bordetella pertussis culture, and its sensitivity is about 6 to 95%. PCR, which is more rapid, has a good sensitivity of up to 98%, and both tests are highly specific with specificity of over 95%. And this is best in the first 7 to 10 days of illness. And how do you treat it? Fairly simple treatment. And the other thing is, because our population are so quick to take antibiotics, and I think post-COVID, azithromycin has become a favorite antibiotic, sometimes cases are inadvertently treated and we never even recognize that it was actually pertussis. So you can use erythro, azithro, clarithromycin, and this both reduces the duration of symptoms as well as severity, as well as shedding and transmission to other people. And in terms of immunization, we've discussed the 2 types of vaccines that are available: the wholesale, which is based on killed Bordetella pertussis organisms, as well as the acellular pertussis vaccine, which is highly purified and has selected components. This is what we refer to mostly when we're talking about baby-friendly vaccines. I don't know if they're baby-friendly or they are mummy-friendly. Yeah, but the acellular pertussis studies have shown less of what we discussed, which is the reactogenicity. Because with the wholesale, a few children will still experience more pain at the site, the irritability, the fever. But I think our focus as a healthcare provider is to ensure that the child gets vaccinated. So if the parent is able and they have that discussion, you should be able to kind of tell them this is the difference between the 2, but certainly do not allow the cost or that concept of a baby-friendly to become a barrier to you immunizing any child, because all the vaccines are very safe and they are very effective. So why did I put measles here? Because we've been seeing more cases of measles. Have you identified cases of measles in your facilities? Yeah, the first one you identified, were you sure it was measles? Why? Because we also haven't seen measles in a long time. Yeah. During 2018, when we had a shortage of MMR vaccines here, it's because there had been an outbreak in New York. amongst a small certain Jewish community, and that outbreak, measles spread like wildfire because it's a very contagious disease. And if you do not have a good herd immunity, meaning about 90+% of children are immunized, it spreads very quickly. So when they realized it's an emergency, vaccines were first diverted MMR to get there. I don't know why it's also why we still can't also get MMR as easily. I think we have another shortage of MMR. But those could be some of the reasons. And what was interesting is because young physicians had never diagnosed measles, CDC had to circulate what do you call it? Like a list of symptoms to help you with case identification. Yeah. So when you don't see something, first of all, it's not top of mind, and then again, you may not recognize the symptoms. So measles is a viral illness that presents with a triad of fever, a generalized maculopapular rash, cough, coryza, or conjunctivitis. So 3 primary symptoms. Fever, very common in children. Generalized maculopapular rash. So a rash that has both flat macules as well as some raised pimples. And it's usually lasting greater than 3 days. So many childhood illnesses give you a rash, but what makes measles distinctive is maybe the way the pattern of that rash appears. So a rash that starts initially on the face, spreads behind the ears, spreads to the rest of the body. As it's appearing on the rest of the body, it is disappearing from the face. And sometimes children are left with skin that is peeling after the measles has resolved. So say in contrast with the roseolas and these other viral illnesses that give you a rash, where the rash just tends to be generalized, appears all over the whole body, or the rash of chicken pox that starts on the trunk. The lesions have a pimple in the middle, you know, a little dimple, so they look umbilicated and spread outwards. So this is a rash starting at the top, a reddish background, but you can see some visible pimples. As it appears at the rest of the body, it's disappearing from the upper parts. And there is a cough, there is a runny nose, there's associated conjunctivitis. You may not recognize another sign we used to talk about called Koplik spots, because these only appear very temporarily. They appear on the buccal mucosa. They are white spots. I don't know how easily also you can recognize them also on our skin tone, but you're told to look for them opposite the molars, yeah? So there should be a white spot that appears there, but only temporary. By day 3, 4 of symptoms, that has also disappeared. So we've been having outbreaks since late 2023. And in northeastern Kenya, it was associated with 5 mortalities. So measles can be a benign illness that presents just with an upper respiratory tract infection, but can be severe enough to present with symptoms of pneumonia, what we call a giant cell pneumonia, and again can invade the CNS. A lot of these viruses seem to like the central nervous system, and it can present as an encephalitis. One complication that I think I saw only 1 case in my undergrad, so I'm even giving away my age, is called subacute sclerosing panencephalitis. So the child recovers from this early episode of measles, but at about 6 to 7 years, they present with memory loss, a change in their behavior, myoclonal jerks, meaning the child is just twitching, seizures, and visual loss. And unfortunately, this is fatal. There's no treatment. You can't come to give intravenous immunoglobulin. You cannot come to immunize at that point. So not only do you have morbidity and mortality from the initial illness, but this small subset of the population that will also present with this devastating late presentation. So again, it feels like we forget how severe illnesses are until they start to reemerge. And then you start to see children even maybe with some neurological symptoms that you can't explain. Is it some old measles that was never treated, never recognized? Yeah. Okay, so when you give the measles vaccine, the first dose gives you fairly good protection of about 93%. And the second dose gives you up to 97% protection. So that's why we, as a country, we really emphasize that they should come back for that second dose of the measles rubella vaccine. If you're lucky, you're able to give them the measles, mumps, rubella vaccine, or if they can afford it. And the immunization is given as early as 9 months in our country, and in most countries from 12 months. But when you give it earlier than a year, data shows that those antibodies wane and the take is not always very good. So that's why as a country, the decision was made that after the 9-month vaccine, we still want one to be given at 18 months. For our population, specifically our HIV-exposed children, because their maternal antibodies wane even earlier, you need to give it at the age of 6 months, yeah? The other thing that we did at Kenyatta when we started to see children with measles is you should actually immunize any child who is in that ward who is over the age of 6 months. Why? Because in a large percentage of our population, those maternal antibodies actually go down from the age of 6 months. That's why you're allowed to immunize even that 6-month-old child. And the 9-month is almost arbitrary, yeah? You're in a high endemic country. A good number of your population do not have protective antibodies by 6 months, but some do. And you see, if you have high protective maternal antibodies, the vaccine does not take as well. So you're waiting for them to wane a little bit to 9 months so that then you can administer the measles vaccine. But you as a healthcare worker should have that knowledge of how does that immunity work? So that if you have a child who is exposed, they're in the next bed, they're 6 months, you diagnose the baby in that ward who has measles, you make the decision to do what? Immunize every contact of that baby because that vaccine could actually be life-saving, yeah? So that's what we had to do in Kenyatta. Consider that if they're malnourished, again, even those maternal antibodies are waning even earlier. So just have that knowledge and be able to make that choice and nobody will fall to you. And again, when it is given early, you still need to give the 9-month dose and you still need to give the 18-month dose to ensure that you get the antibodies up to the proper level for protection. So I just put up this scorecard and I'm sorry that it's an old one. I was looking for a more recent one, but I think it was just to highlight that we're not doing as well as we should be in the area of immunization. So the ones in green are where we have coverage that's above at least a cutoff of 60, no, yeah, about 60%. But you can see some counties are in the red. So the proportion of children less than 1 who had received Rota 2, yeah, you could see many counties were actually doing badly. Even the ones in yellow, we are not performing particularly well. That is looking at DPT1 coverage, DP2 coverage. And when you have counties going as low as 53%, and then especially for that third one, you can see how low the rates are. It tells us that as healthcare workers, we still have quite far to go in terms of just making sure that that child who presents with whatever illness in our healthcare facilities is immunized. So ask for the book at every visit, check that weight, check that all the vaccinations have been received. So vaccines are important in interrupting transmission. You only achieve herd immunity when you have over 85 to 90% coverage. Low vaccine uptake remains a threat. And we are now having resurgence of diseases due to both low uptake and social disruption. So what is our role in all of this as healthcare workers? Yeah. So that brings me to my next quite brief presentation on vaccine hesitancy. So what is vaccine hesitancy? This is the reluctance or refusal to vaccinate despite the vaccines being available. And I like this picture because our focus is on these people here who have questions, yeah? The ones who are reluctant. There are some people who are just vaccine deniers and you'll spend all your efforts there and they have all the papers about how MMR causes autism, yeah? So you can also just give that person the information, but the one who is asking questions, daktari hii ni lazima hii nipe. Sasa hii ni pesa ngapi? Engage that person, yeah, and be able to educate them about the importance of immunization. And vaccine hesitancy, you can see, is being recognized as one of the threats to global health. Imagine it is more than even global influenza pandemic. The fact that we're now having resurgence of vaccine preventable diseases. So in the continuum, we've said there's this ideal patient who accepts everything. Then we have those who accept, but they're not sure. Some are accepting and they're like, lakini yu sasa huwezi mdunga shindano tano. Si upe leo mbili, alafu nitakuja. Hii ingine nasikianga atalia sana. And then these ones who are refusing, but they're still asking questions. And then there's the denier who is refusing everything. So the population we're talking about addressing is these people who are accepting, asking a few questions, asking whether you can delay. I have one patient who I see in private practice who I think we've been giving one immunization per month from the time the baby was due. So now when things like you hear there's a measles outbreak, you have to advise them that even though these are due, remember, by the way, you need to prioritize things like measles. Even when you find that person who has delayed or has never received immunization, measles is a priority, yeah, for that late presenter. And then now you come slowly with your DPT and hexaxins and rota if it has been bypassed by events, yeah? So you do come across those patients, and rather than chasing them away, just try to come up with a plan that will give that child the best protection while making them continually understand the risk. Then next time you're like, let's do two, because now we are becoming very late. So I think we finished that primary series when that child is heading to 2 years, but we have reached where we have reached, yeah? So what are the implications of under-vaccination? So it's a hesitancy to immunization programs. And like we said earlier, this is a problem worldwide. And 1 in 5 children miss life-saving vaccines every year, leading to 2 to 3 million deaths. And 2018 global coverage of the DPT3 was about 86% and 84% in 2022. Our own local statistics, like you've seen for some of our counties, is in the 60s. 83 countries have yet to achieve the targets of 90% or greater coverage of DTP3. So another thing that just came to mind as I'll just going through these slides again is, as we start to have vaccine shortages as a country, that is a big threat to us. So as healthcare workers, we have to have advocacy. Why? Because when things pass and a child has not been immunized, and according to the mother, the baby is fine, you see you're also passing a message that maybe these vaccines are not very important, yeah? So we had reached a point of very good vaccine acceptance within our population. But see, people stayed without vaccine during COVID, including Rota. So I'll tell you, hata sikupata hiyo na mtoto hakugonjeka, yeah? So that momentum is lost, and it starts to seem not important when we seem to be okay without it. But you see, it will be years of poor immunization and a large unvaccinated population, and it will just be in Sodom and Gomorrah. We won't even be believing what will be happening in our hospitals, okay? So I feel we are not even making enough noise, yeah, whether as doctors, as nurses, to really just come out to protect our children, because you lose so much ground. By the time they're now available again, starting those stories of immunization becomes a little difficult, yeah? So, but most people luckily seem to trust vaccines, and many people think vaccines are safe to use. This was a global survey done in 2018. And so again, this little population that we're addressing there in the green are the people who we are targeting. So we said successful immunization is a continuum where we have the healthcare worker, we have the family, we have the immunization system. So in terms of the family, do they trust the system? Do we provide adequate information? Is it accessible? Is it available? Is it culturally accepted? Have we talked about the adverse effects satisfactorily? So when mom comes back with fever, and maybe even the child had a respiratory infection, are you able to reassure her, by the way, this had nothing to do with the vaccine? You know, once the child is vaccinated, if anything happens, even that leg sijui gets broken, you're told unajua alidungwa. That is the event they remember. Mtoto alidungwa, alafu alipokaa nikaona hata sasa haongei. You get me? So it's now, do you have the patience and the information to be able to reassure and educate and say, even if we had immunized, hiyo haitazuia homa. Kwa hivyo alishikwa tu na homa, na homa sasa imeleta joto, but still come back for the next immunization, yeah? Immunization systems, we've talked about, are they available? What is our vaccine supply like? Do we have an adequate cold chain? How are we managing our stocks? Are we handling them safely? Are we thinking about, as our country, our long-term plan in terms of being able to afford the vaccine as the Gavi funding continues to be withdrawn? As the healthcare worker, do you like your job? Are you smiling at the mom? Yeah? Are you holding the baby, reassuring her, looking at the card, advising her about the vaccines? Are you able to redirect her when she needs help? Do you have adequate training like what is being provided to us today in forums like this? Do you have good support supervision so that you're confident if you give the vaccine at the wrong site, if you made a mistake, you're able to report it without being penalized? Yeah. So are you also working in an environment that enables this whole vaccine cycle to work well? So how do we increase confidence? We are still the ones who are going to build trust, because the healthcare worker remains pivotal. You're the most trusted advisor, you're the biggest influencer of immunization. And we support you in order for you to provide that trusted, credible information. Again, we come back to COVID vaccines. What was the uptake of COVID vaccines in our country? Not great. What was the uptake amongst healthcare workers? Worst. Imagine, we had a study in Kenyatta. I think nurses were in the basement, down, poor uptake. Doctors were not far behind, yeah? So if we are giving people a vaccine, but we don't trust it enough to take it, what is the barrier? What's the barrier? Not enough information, yeah? Sometimes maybe you survived COVID, like some of us without immunizations. We were working in the COVID wards, trusting in God every morning. So when vaccine came, we're like, but I've been fine, yeah? But did we lose colleagues to COVID? We did, yeah. We lost a large number of colleagues. So me being okay does not mean the next person will be okay. So, and if I don't take it, I'm not encouraging the next person to take it. So at some point, I just actually went to my ward, looked for the nurses. I'm like, who has not been immunized? And we all walked to the immunization center together and got our jabs together. So you could just see, what does it take for me to be able to build vaccine confidence? If there's some information that I don't understand, do I have the right sources to get that information? Because if you don't trust it, I'm not sure how our patients are supposed to trust it. So it is trust in our systems, the government, it is trust in the vaccines, it is trust in the healthcare worker. And how do we build trust? So you listen, don't dismiss people when they come with their papers. There's a forum I'm on where we just have an ongoing debate about COVID even now. And you respect people's opinions and you listen, yeah? And then you also give them your opinion, you give them time to think about that. You understand what is the root cause of that hesitancy. And then you engage them at that level. What do you think is the problem? Did you have a bad experience at some point with infection, with the vaccination for one of your children? Is it us who did not address maybe those concerns adequately? And then people relate to your own real life stories. So you're able to tell them, you know, I have seen children who have come in with measles. If you don't immunize your child, this is a possibility. So since you as a parent have the ability, why not give your child that chance, you know? And because it's a vulnerable child, most parents, if you address them well and you relate to them and you're not judgmental, they will actually give you a listening ear. We need to also look at the role in the media. Are we writing about it enough? Are we out there on social media? I see our younger colleagues are very active in that social media space, giving that information. When I look out in this room, most of you are digital people. So you don't even need newspapers. You just need even your online audience within the community, engaging people in the same. So be proactive, avoid jargon, and contribute content where you can. And we've had colleagues who are very passionate about it. They share their experiences and they become big advocates of immunization, and that is another strategy, all right? So we can also build coalition with civil societies. We have our national immunization days. We should actively participate in them, identify community mobilizers, and the most important thing is that we are equipped to have those conversations around vaccines. And I think that may be my final slide. Yes, because we are the biggest influencers at the end of the day. So we want all healthcare workers to be supported so that they provide trusted and credible information on immunization. And I like that slide because the family that anti-vaxxers together will infect the community together. Yeah, that reminds me, there's also a chickenpox outbreak, isn't it? I mean, we're just having outbreaks of one thing after another. So, and all of these are things for which we have immunization. So a little case, and I think already we have most of this data. So this is patient AM, 3-year-old male who has been referred to your facility from Garissa, complaining of cough, fever, and runny nose for 4 days, as well as lower limb pain and weakness for 3 days. He lived in the refugee camp with his parents, and he has received OEP up to dose 3. And he's a previously well child, and 2 children in the camp have reported similar symptoms. So now I'm sure, okay, on examination, the child looks well. The main findings are in the CNS, where he's alert. He has reduced muscle tone in his upper and lower limbs, but sensation is intact. The other significant finding is a low SpO2 in room air, but it goes up when you administer oxygen at 1 liter per minute via nasal prongs. He is tachypnic and he's also febrile. So what is your diagnosis? This one is almost just spoon feeding people. So when you see that child, the diagnosis of acute flaccid paralysis must be top of mind, yeah? We've discussed other differentials. There are things like Guillain-Barré syndrome, yeah? But I think really the emphasis is that child with paralysis, we don't want you to miss polio and take the appropriate samples for stool for identification. You manage the child's supportive care. Unfortunately, there's no specific care. And I think we've talked at length about the prevention. And that brings me to the end of my presentation. Asanteni sana. I had a small video I wanted to show. I don't know if you're ready to play it. Okay, good. I can answer a few questions as we wait to go take tea. Is tea ready? When my throat feels dry. Is there another? Thank you. Thank you, Catherine. Is there another microphone or I take this one round? Okay.
Thanks, Dr. Anne, for that nice presentation. Just a clarification. You talked of immunizing the children in the world if you have a case of measles at 6 months. Just clarify whether you need to revaccinate this child at 9 months, at 18 months again.
Yes. Yes, thank you for that question. If you immunize a baby early, just like we do for our HIV exposed infants, they're still going to follow the same program of revaccination at the 9 months and the revaccination at 18 months. Why? Because this one you're giving, you're not sure about how well it will take. Because traditionally we don't give it at 6 months because a lot of patients still have high levels of maternal antibodies. And if those levels are high, then you don't mount a very big immune response. So you do not have antibodies that will protect you in the long term. So you give it so that at that point, they start to develop some antibodies that can prevent infection that has come earlier. You're hoping they still have some maternal antibodies, the baby is still breastfeeding, is still protected that way, but you're doing it as a protective measure. Then you're still going to do the 9-month usual vaccine as well as the booster given at 18 months. And you see, because that's a public health issue, it should be the moment you have a child within your wards, it's something that you should flag as a nurse so that you're even aware, do we look and see, are there children here who have not yet received immunization? And do we need to give them a dose of the measles vaccine? Yeah. Measles kills young children. Yeah.
I wanted to ask, is it safe to give a child to give measles vaccine, a child who is 6 months old, and they're traveling to a measles clinic?
Yes. Yeah, brief answer is it is safe. You see, the goodness of vaccines is they're safe. So even if you don't give it at the right period, and the right period, I can tell you, is debatable because WHO gives a country-wide guidance and tells you, for example, measles vaccine can be given from 6 months to any age. So here we are doing 9 months. UK, they do 12 months. UK, Canada, US. Why? Because they don't have a lot of measles. All right. So it is perfectly safe. Yeah. So even if you give it early, it is not that you will have a reaction because you gave it at the wrong time. It is that the level of maternal antibodies may not allow you to achieve the correct level of protection. Yeah, so that's why we delay some vaccines until maternal antibodies have waned, but it is safe. So if they're traveling, you actually need to advise them and immunize them early. And during an outbreak, that's why I'm emphasizing that vigilance, because we're now having many cases in the community. So don't just treat that child who you saw in casualty or admitted in the ward. It means you're actually thinking who else in this ward is vulnerable and has not yet been immunized. Yes. Spot diagnosis, and then I'll buy you lunch. And I recognize this video is courtesy of my colleague in infectious disease, Dr. Mbuthia. Yes. What do we see? A young preteen girl, yeah, coughing and coughing and coughing, and the cough is not ending. The mom allowed us just to take this video for educational purposes, yeah? Okay, diagnosis, pertussis, yeah? Yes, everybody gets free lunch. Yeah, so that cough is, it's called a whooping cough because you cough, cough, cough. Yeah, you can barely draw a breath between coughs, and it's characterized by even breakage of the vessels in the conjunctiva, because you just have that persistent cough. What I have seen then in the younger children in Kenyatta is the same thing. You have this little baby. Remember, before 6 weeks, the maternal antibodies could be low for whatever reason, but they haven't yet received that first immunization. So pertussis is a diagnosis you must have at the back of your mind. When the baby is just there coughing, they're on oxygen, but you can actually see an almost continuous cough. And that's important because your usual expungent are not going to treat it as effectively as you recognizing that this could be pertussis and giving a macrolide. Yeah. Yes. And we're seeing more, I think, cases when we do now the biofires, because they're available, we are identifying more of the cases of pertussis. Yeah, biofires are always there also tongue in cheek, because they also identify many innocent bystanders. You know, when you have a PCR test, it will tell you everything that's in the respiratory system. But when you have a symptomatic child, it gives you a good clue as to what could be going on. Any other question? Yes. Okay.
So in terms of these patients who maybe come into our country from abroad, expats and all that, like you've mentioned, they have a different vaccination schedule depending on what country they've come from. And some of them come and deliver here, and it's a bit easier to transition into our schedule. But those ones who the children have received some vaccination, say in Europe, the States, and then they come here and they want to continue, how do you advise on integrating the vaccine schedule they have and what we have locally?
Okay, I advise them to go more by the Kenyan schedule. So for example, rather than delaying the MMR until 1 year, I still advise them, give it at 9 months. Because you can imagine, they're interacting with our local population. So this child catches measles and you're there waiting for Canadian vaccination schedule. You know, at the end of the day, you as the healthcare worker, you're the one with the information. Them, they don't know about epidemiology and what is here. So I think it is that thing we're saying, information is power. So you're able to tell them, because of our local epidemiology, we prioritize certain vaccines at a younger age. And one of those is measles. It's an important one. Another one is meningitis. And in a sense, I feel because they've not even had some of those diseases where they're from, if there's even possibly very low immunity, yeah? So you would prioritize it and then you fit in, because they actually tend to have fewer vaccines than we do. Even in terms of, say, the number of doses of the pentavalent that they are giving, you know, they'll even give 2, it is quite delayed. When they come here, just advise them to catch up, because the risk is higher just based on the prevalence of diseases that we have here. And then you speak with confidence. Yeah, that's what I've realized. You arm yourself with information. You know, not even you, they ask, and then now we're all Googling together. And now already they're like, oh, you hata hakujua, yeah? So I think that's why forums like this are good. They remind you, go back, look at that vaccination schedule. What does this mean? If a patient has challenged you with a question, read about it, because that question may come again, yeah? Where you don't know, it's also okay to say, you know, I don't have that information and I'm going to get it. Or you can refer to a colleague who is dealing with that area, but have some basic information that inspires confidence, yeah? Yes. Okay, I think we are ready for tea, but we are still here with you until the end of the sessions. And like I said, we can continue to interact. Thank you, Doc.
Okay, guys, please give another round of happy applause. I think right now you can tell if someone is having whooping cough and not choking on a chicken bone.
That's a differential.
Okay. So we have a very short break. We'll make it please 10 minutes, and then we'll be back for the presentation by Dr. Catherine Mwenda on vaccination in special groups, which is a very interesting presentation. So please, you can take a small potty break, but we'll be back in 10 minutes.
Okay, we're going for tea. We have not even had breakfast. Yeah. How are you doing?
So after the short break, we're back. We're introducing Dr. Catherine Mwenda. She's again pediatric hematologist, oncologist who will be presenting on vaccine in special groups. Welcome, ma'am. Thank you.
Thank you, Dr. Maya. As you heard my name is Dr. Mwenda Catherine. I'm very happy to be here with you, giving this talk on
Vaccination in special groups. I work at the Kenyatta National Hospital in the Pediatric Hematology Oncology Department. And I'd like to just show the outline. So the outline of our talk today, we'll be looking at a brief background. Then we're just going to have an overview of how the types of vaccines that we use, how the vaccines work. And then we are going to focus on now the special groups that we come across every day. And then finally, we'll have a Q&A. So as a background, I think we've been discussing this all morning, that immunization is a global health and developmental success story, saving millions of lives every year. And one of the strategic objectives of the 2011-2020 Global Vaccine Action Plan, the GVAP, is for the benefits of this immunization to be equitably extended to all people. So this approach will encompass special groups at increased risk of vaccine preventable diseases. So I'm going to talk about pregnancy as a special group. We'll talk about the preterm infants. We'll talk about the HIV infected and exposed infants. Those with chronic conditions such as sickle cell anemia and the immune compromising medical conditions. Those are the groups that we'll focus on. So what are the types of vaccines that you know? So we have the live vaccines, okay? So what are live vaccines? When you talk about live vaccines, because this is something we'll talk about in the special groups. So what are live vaccines? Any takers? Anybody? We give these vaccines every day to our children, right? So what are live vaccines? Where is the mic?
Yes, what are live vaccines?
References are basically parts of the antigens that have not been killed and put in the vaccine.
Okay, thank you for that. Yeah, so live vaccines
are vaccines that contain the weakened forms of live viruses or bacteria. And these weakened forms, they will replicate in the body, but do not cause disease. But they are able to provoke a very strong immune response, and that is thought to be quite prolonged and long-lasting, okay? So you have the live virus and bacteria, but they are weakened forms, but they do not cause disease, okay? So examples of this are like the hepatitis A, okay? Sorry, the MMR, the varicella virus, rotavirus, the yellow fever, and the BCG. So those are live vaccines. Then we have the inactivated vaccines. So these are vaccines that are not, you don't have now, they're not live. So the viruses, the bacteria are actually inactivated. And so these vaccines, when you vaccinate the person, they're still able to stimulate an immune response, okay? And an example is what we're talking about, the inactivated poliovirus, which is given via injection, hepatitis A, the rabies, the flu virus, whole cell pertussis as well. We do have these vaccines, and we've talked about one in the morning, the meningitis, the subunit, recombinant, polysaccharide, and conjugate vaccines. So example was like the meningococcal vaccine. So this type of vaccines have little pieces of the virus or the bacteria. It could be a protein, it could be a sugar, okay? And these now pieces are used in the body to stimulate the immune response. So examples are those ones like pneumococcal, conjugate virus, the meningococcal, Haemophilus influenza type B, pertussis, and also the hepatitis B. Toxoid vaccines, we have, these are vaccines that they target the toxin. The toxin that is produced by the bacteria, not the bacteria itself. So that toxin is sort of rendered harmless, and then now you're able to inject that and stimulate an immune response. And examples are tetanus toxoid and diphtheria, and they come as a combination. Viral vector vaccines are such like the Johnson & Johnson COVID-19 vaccine. So in this type of vaccine, you have a vector. The vector is the messenger. So you have a harmless virus, okay? So then you inject the genetic material into that vector to deliver that genetic instructions into the cell. Then you have the cells now producing antigens, okay? And now, again, stimulating antibody production. So an example is like the Johnson & Johnson. While the Pfizer COVID-19 and the Moderna, those were messenger mRNA vaccines, okay? Almost similar to vector, but in this case, you have just an mRNA, a messenger RNA molecule being delivered as part of the vaccine. So it will go into the cell, it will give instructions to produce some antigens that will stimulate the body to produce antibodies. So some of the type of vaccines we use on a day-to-day practice, and I thought I'd just explain some of them so that it's all clear for us, okay? So generally, how do vaccines work? Magic. How do vaccines work? Anyone want to have a go? We have this projected. No takers? So I have this cartoon. It shows So as we have discussed, the vaccines will contain weakened or killed pathogens or a protein derivative, okay? Then once that vaccine is introduced into the body through whatever route, oral, IM, subcutaneous, right? It causes the body to produce immune cells. What immune cells are these? Yeah, T cells and B cells. What produces antibodies? The B cells, correct. So the body will produce these immune cells with memory that can produce antibodies. So what happens when you're exposed to these bacteria or viruses, this pathogen? You have a robust antibody response on subsequent exposure. So basically that's what vaccines do, okay? So for vaccines to work, the individual must be able to meet certain criteria, okay? One, be safely exposed to the pathogen through the vaccine, must be able to mount an immune response to the vaccine. So you must have a functioning immunity, isn't it? All right. And the individual must be able to create memory cells, because at the end of the day, you don't want to be ambushed, right? Create memory cells so that on subsequent exposure, you have a robust immune response, okay? It's fast, it's effective, right? So I've said it requires a functioning immune system, but there are several different diseases that can interfere with this, okay? So I just put up the routine immunization schedule. So we have the top half that is provided by the government, so what we call KEPI, Kenya Expanded Program of Immunization. And we have the bottom half. This is provided in private facilities. So quickly, let's just look at how we vaccinate our children. So we have at birth, they do receive BCG and OPV. Are they live? Are they inactivated vaccines? We said there. BCG is live. It's a live vaccine. People are sleeping. OPV is a OPV. Oh, it's live. Huh? So 2 live vaccines at birth. The addition in the private, they give hepatitis B at birth. So that's the addition. Then again, the schedule is the same, whether you go to a government facility or you are in a private facility, you will receive at 6, 10, and 14 weeks, you'll receive the pentavalent, the OPV, the PCV10, okay, pneumococcal conjugate vaccine. Then you'll receive the rotavirus and IPV, which is injectable or inactivated polio vaccine. All right. So when do we give the IPV in government facilities? At 14 weeks. And we have just discussed why Dr. Macharia has explained to you why we are doing that as a part of the strategy of eradicating polio virus. So what is a bit different here at private, we tend to give them a hexavalent, right? Pentavalent is 5, penta is 5. So there is diphtheria, pertussis, tetanus, and in government facilities, the type of tetanus is, that means the kind of pertussis is whole cell, right? Tetanus. Then the fifth one is, the fourth, HIB, Haemophilus influenza type B, and the fifth one, hepatitis B. So what's the sixth one in the private facilities that offer? IPV, okay? So you find that in private facilities, you give IPV as 6, 10, and 14 weeks compared to government schedule where they give it only at
14 weeks. So still they'll give the OPV 1, 2, 3. Now, there are facilities that have the PCV10, which has 10 serotypes, and there are those facilities that have PCV13, that has 13 serotypes against pneumonia, the pneumococcal bacteria. Now, what do government give? Do we give 10 or 13? The government schedule, we give 10, okay? So 13 is mostly in private facilities. Then they will receive the rotavirus, and the IPV is sorry, oh my, who's Lisa? Sorry, so if they are receiving the pentavalent, then they'll get the injectable poliovirus again at 14, all right? Then 6 months, they come in for vitamin A, but if they're in the private facility, they will get the flu vaccine, sorry. 9 months, what do we give in the government schedule? Measles and rubella. And if you are in endemic areas, yellow fever, okay? Now, in the private facility, we do give the meningococcal. It comes in here, all right, at 9 months, in addition to the MR or the MMR. So the additional M is mumps. So measles, rubella, and in the private facility, they get mumps, measles, and rubella. So I think we explained why we're giving the meningococcal at 9 months in Kenya, because it's associated with high mortality. And so we start to introduce it at 9 months and repeat another dose at 12 to 15 months. So at 18 months for the government schedule, we do have a repeat MR. However, in the private facility, you can even repeat the MMR as early as 15 months, okay? Though for uniformity, I put it there at 18 months. So the reason I've highlighted the meningococcal, the meningitis vaccine, is because, as alluded earlier, you find that in developed countries where they have low mortality, it is usually given at 12 months, the first dose, and a repeat when they're joining school. So they get at 4 years to 5 years. But for us, it comes earlier because we are at a high risk of mortality, and it's a high endemic area. And then always remember the vitamin A. When does it start? At 6 months, and then every 6 months, up to 5 years, okay? And lastly, we have at 10 years, we have the HPV, okay? So there are usually 2 doses, and for now, the target in the government facilities are girls, all right? Though in private facilities, we don't turn away the boys. We will vaccinate both, okay? There are some boosters of some vaccines in the pentavalent. We give the boosters at 2 years and also 5 years, okay? So that's just the schedule as we use in Kenya. And the ones that are bolded are offered in private facilities. So let's start the focus. Now we look at the special groups. Pregnancy is one of them. What do we vaccinate our pregnant women? Do they get any vaccination? Which one? Any other? Flu? Any other? So when do you give the tetanus? When they come to you? Sorry, I'm hearing whispers. 16 weeks, okay. Anyone who vaccinates later on? And the flu? Anytime?
Anytime? Okay, let's see. So it's good to vaccinate the pregnant women because it's an opportunity where you want to protect both the mother and the fetus, and by extension, the infant even after birth, because the infant has the maternal antibodies. So it's considered safe to vaccinate pregnant women with the inactivated or toxoid vaccines. Avoid the live vaccines because they are potentially harmful to the fetus. Okay, so yeah, we do vaccinate against influenza. We give them the inactivated influenza vaccine, the tetanus on its own, or the tetanus diphtheria vaccine as a combination. So how about the preterms? Preterms and low birth weight babies, they are also a special category. So according to the WHO and the Advisory Committee on Immunization Practices, preterm infants who are otherwise well should be immunized according to the same vaccination schedule as a full-term infant. Okay, so to ensure early protection, you want to vaccinate preterm infants according to their chronological age rather than their corrected age. What I mean by that is, I'm born today and I'm born at 34 weeks. In 2 weeks' time, how old am I? I'm 2 weeks, isn't it? I'm not 36, corrected gestation age of 36. Almost like you're waiting for 40 weeks, then now we are day one. You understand? So we use the chronological age rather than the corrected gestational age, and also regardless of birth weight. And this one has had a lot of contention, right? Okay, we shall discuss those contentions in the Q&A. Hepatitis B vaccine, again, we don't routinely vaccinate our babies against hepatitis B in the government facilities. But now, if we are vaccinated with hepatitis B, I've seen most of you are coming from Gertrude's, right? And like I think some from other facilities. This dose, even if it's given to infants less than 2 kilos, you have to repeat the vaccine when a child attains more than 2 kilos. Again, just because of the immune response, that it would be a poor immune response in children who are less than 2 kgs. And that's also a recommendation by the WHO, ACIP. And the PCV booster dose in the second year of life, they should also receive the PCV booster at year 2 if they've received the 3 primary doses. They are the one at 6, 10, and 14 weeks. Okay. So I know some of us might think, okay, why is it that the government schedule is so much different than the private? I think they have to rationalize the resources, because you can never have adequate resources. So look at this third bullet, sorry, this one about hepatitis B. You know, so what's the point of vaccinating when a child is less than 2 kilos if you're going to vaccinate again anyway, right? And then still give them at 6, 10, and 14 weeks. So those are almost like 5 doses. So that's why in terms of rationalizing in the government facilities, let's give the hepatitis B at 6 weeks. You understand? Let's move on to immunocompromised persons. So who are these people? So it can be quite difficult to determine the extent at which an individual is immunocompromised. So it could depend on the illness itself, the medications the person is taking, and also other considerations. So who are people? The people who are immunocompromised may have challenges in these ways. They have reduced protection from previous vaccines, all right? They have reduced response to the vaccines given, therefore may need more boosters, all right? They might be at increased risk of vaccine preventable diseases, and increased risk of adverse events as a result of the vaccines. Okay. So who are these immunocompromised people? We talked about the immune cells, right? So you have immunodeficiency of these immune cells. They could be the B cells, the T cells. So the B cell comprises of the humoral immunity. The T cell is cell mediated. Then you have the complement and the phagocytic. So those have primary immunodeficiency of any of those immune function. And those are the examples of some of the conditions that we see with primary immunodeficiency. We don't see much of this, or perhaps we are not diagnosing these children, okay? Then we have the secondary immunodeficiency. Secondary means it's secondary to something. You're immunocompromised as a result of this, okay? There's something in the background. So examples are like HIV infection, malignancies that we are starting to see quite frequently. And we are starting to see, people going to get transplants, immunosuppressive therapy or radiation therapy, asplenia or in sickle cell disease, and even in chronic renal disease. So I'll focus a bit on this secondary causes. So let's look at the HIV positive infants and children. So I remember as a student when I was, I think in undergrad, there was a lot of discussions on HIV and vaccinations. Like it wasn't very clear as it is to us right now, whether they should be able to receive vaccines, should they get the live vaccines or not. So there was a lot of research, robust research that has taken place over the years that is able to inform some of the guidelines that we have today. So HIV is not a contraindication to vaccination. We all know that, right? And this includes the live vaccines such as BCG and measles. The considerations would be in the asymptomatic patients. These are the children who don't have advanced HIV infection. They should receive BCG at birth, and they also receive the measles at 6 months, all right? They will go on to receive their measles vaccines at 9 months and 18 months. So it seems like it's an addition for the HIV exposed and infected infants. But if they do have symptomatic infection, you can see these are symptoms of advanced HIV disease, then you want to delay, you shouldn't give the live vaccines. And this recommendations is actually from the 2023 Kenya National Immunization Policy Guidelines. So this is the immunization schedule for the children who have HIV infection and who are also HIV exposed. It's similar to what I had shown earlier, okay? So the only addition, so we had said birth, they will receive OPV and BCG. Then at 6 weeks, they'll receive the OPV, the pentavalent, the pneumococcal, the rotavirus. And that is at 6, 10, and 14 weeks. At 14 weeks, there's an additional IPV. But now at 6 months, they will receive the measles rubella vaccine. And then it continues like the rest of the schedule, the 9 months, 18 months, and then the HPV at 10 years, okay? Let's quickly look at sickle cell disease. Have we heard about sickle cell disease? What is sickle cell disease? It's a hemoglobinopathy. It's an issue with the hemoglobin, okay? So what is so special about sickle cell disease? And what's so special about it? It's very, yes. Yeah, when we're talking about them as immunocompromised people. Anybody?
The neurological organism is compromised.
Give her the microphone. Thank you. Thank you. Yes. So what are some of the functions of the spleen that you may know about?
So it's an immunological organ. So in sickle cell disease, it will be compromised. They can be splenic sequestration, or the disease can progress such that there's removal of the spleen, usually to asplenia. In terms of function of the spleen immunologically, it's a primary, I think, or secondary lymphoid production organ. Yeah. Yes.
Makofi kwake. We all know where the spleen is, right? The left upper quadrant.
Yeah, so as she has rightfully said, it's an immune organ. It is a filter. Think of it like a filter, like a kichungi. So it filters damaged cells and removes them from circulation, because all this blood that circulates our body has to pass through the spleen. So the spleen is able to identify the damaged cells, removes them, identifies pathogens, and also it has resident macrophages. So it has immune cells there ready to destroy any abnormal, pathogens their way. So in sickle cell disease, one, their spleen does not function well. Even before it sort of undergoes autosplenectomy, even if it's present, it doesn't function well. Okay, so that's one. So the children with sickle cell tend to be immunocompromised because of that. Then two, also because of frequent infections that occur at the spleen, because how much blood is pulled to the spleen at any point? About 60 to 70% of blood is pulled in the spleen during circulation. So it undergoes infection, and so even when you search for the spleen in most of these children, it's not visible by the time they reach 5 years of age. So for that very reason, the sickle cell disease, we have special considerations in how to vaccinate them. Okay. And just another thing to bring about is they're at risk of severe infections from which type of bacteria? Encapsulated bacteria. These are like examples. Pneumococcus, strep pneumo, yes, thank you. Haemophilus, influenza type B, and Salmonella typhi, okay? So vaccination of children with sickle cell is just like any other child, but special considerations or additions. So they will require the pneumococcal polysaccharide vaccine at 2 years, okay? So they will have received the PCV, right? They are receiving the PCV at what time of their lives? At 6 weeks, at 10 weeks, and 14 weeks. And usually if you're following the government vaccination schedule, that's done, right? That's it. But if you have sickle cell, you need to advise the patient to receive a booster. And this is the PPSV at 23. It has 23 serotypes at 2 years, and then at 5 years, and every 5 years going forward, all right? They should receive the influenza vaccine every year. So that's the second vaccine they require. They do require the meningococcal vaccine. 2 doses, again, as we mentioned, for those below 2 years, and 1 dose once they're above 2 years of age.
And lastly, the Haemophilus influenza type B. They require a booster at 18 months. Does the HIV, have you ever seen a HIV vaccine on its own? Yeah, so it's non-existent, at least not in Kenya. And okay, so Florence says it used to be there, but now it comes as a combination. It's that pentavalent. So what do we do for these children if we just want the HIV? You give them the pentavalent, okay? Now, from experience, I see children, we run our clinic in Kenyatta on Mondays, the pediatric hematology clinic. So we see a lot of sickle cell disease children. And so when they come to us and we are sensitizing about the vaccines, because we start early, as Dr. Masharia said, you have to have these discussions with your patients even before they are to receive their vaccines. So you have a talk with them and you prescribe these vaccines. And we would prescribe it like this. We'd write the pneumococcal vaccine, the influenza, the meningococcal, and here we put the pentavalent. And we advise them they can get one every month, one every month for 4 months. And so we write it as a prescription. And I always write my number because you know what happens? They always call me back distressed. There's a nurse somewhere, and I was like, hizi ni gani? Mtoto wako wako 3 years, hapati hiyo. You see? So I always do that because I know they will get some challenges along the way. Why is this child getting these vaccines and in this schedule? But it's very important for the reasons we've talked about, okay? Even in the prescription, I write sickle cell disease so that it's very clear as to why we are vaccinating like that, okay? So if you come across these children who are coming for vaccines, please don't turn them away. Just, the parents, if they're not equipped with the information, they'll just be told, no, you're not meant to receive these vaccines. And what will they do? They will leave. They'll just go. There are those who are more empowered and like, talk to my doctor. The number is here. And I do get some calls from some vaccination centers. So just a little bit about the pneumococcal vaccine. There are 100 capsular serotypes of strep pneumo, and all of these can cause disease. But what do we have as for our vaccines? We do have the current vaccines we have the polysaccharide vaccine, which has 23 serotypes. It covers 23 serotypes or strains of the strep pneumonia bacteria. And we have the conjugate vaccine. The current one that we have is the PCV 10 and 13. The 15, 20, I don't think we see that not in Kenya. And as I think one of our speakers, Dr. Mate, talked about conjugate vaccines. Conjugate vaccines produce a more robust response because of that conjugation. For the pneumonia vaccines, they are all polysaccharides, but when you say pneumococcal conjugate vaccine, it's this polysaccharide which is on the conjugated with another protein to make it more immunogenic. Yes, we learned that this morning. Yes, to make it more immunogenic. So the idea is let them be vaccinated against the PCV first, and then the polysaccharide one, the PPSV, comes after 2 years. When you give it before 2 years, it doesn't mount a very robust immune response. Okay, hope that's clear. So just the last bullet, the polysaccharide vaccine, the pneumococcal polysaccharide vaccine 23 will be recommended for those who are above 2 years and also those who are more than 65. I think that sentence does not look correct. But I think that's how it is. For more than 65 years or above 2 years with underlying issues. All right, so let's move on to malignancy. This picture here is a slide that has very monotonous big cells. Those are leukemic blasts. So just an example of a malignancy. So in malignancy, we have a lot of challenges because now that is my area of specialty, that we do have children who have cancer, whether it's solid organs or blood cancer. So our recommendation is these children will not receive any vaccines once we diagnose them with malignancy and they are on some form of immunosuppressive therapy. So we do get children with cancer right from birth, right? No, and we have children who come at 1 year, at 6 months. Have they completed their vaccinations? No, they haven't. But that is where we've put a hold. But we do support these children. We have put a lot of consideration in supporting them against contracting infection and even on treating the infections that they may get. So what we say is chemotherapy is broad, radiation therapy is also broad, okay? So after chemotherapy, we give it minimum 3 months. So we say 3 to 6 months, then we can restart vaccination. And here we are restarting, okay? Other than the BCG, which we don't give, we'd probably first investigate whether they are exposed to TB. We would give the other vaccination series. We'll have a schedule and they'll be able to receive. However, we do delay the live vaccines. We would start with and that's why we're going through the type of vaccines so that you understand, okay, this what each type of vaccine is. So we would give the inactivated vaccines, the conjugate vaccines, but we will delay the live vaccines as a last, okay? And we would start from, well, in Kenyatta, we do start from 6 months after chemotherapy, though there is some recommendations that we can start at 3 months. So as I said, live vaccines are during chemotherapy are contraindicated. How about the transplant recipients, hematopoietic stem cell transplant recipients? We have a few transplant recipients who've come on follow-up in our clinic. So this is something we are seeing, and we actually have to make careful considerations as to who will receive, how they will receive their vaccines. And some of these considerations are timing. Okay, so in terms of timing, we want to know the type of transplant. We want to know whether there's graft versus host disease, and if they are still taking their immunosuppressive drugs. Okay, so pre-transplant, some considerations are done. We can do antibody titers to see whether the child has adequate immune response by looking at the antibody titers. But post-transplant, again, we want to start with the inactivated vaccines from 6 months. But with those considerations, looking whether they have GVHD and if they're still taking their immunosuppressive drugs. So we would also delay the live vaccines for last. And of course, this will depend. The other considerations, we want to know if they have a functioning immunity. So if you have undergone a hematopoietic stem cell transplant, how do we recognize that your immunity is good? We would look at the blood counts, we look at the lymphocyte counts, and we'll be able to tell if the immunity is good, because you must have a functioning immunity in order to give vaccines. Okay, so it's not as simple as it looks here. Really, it is case by case. And this one needs a lot of discussions, not just by one person. You need discussions with the hemato-oncology team. You need to communicate with the infectious disease team because they also need to guide you on how to go about this. So other special groups, we have children who have malnutrition, isn't it? We see them every day. So these children have weakened immune response systems and they are prone to infections. Vaccines are actually quite important in this group because they are at a higher risk of death from infections such as meningitis, measles, TB, sepsis. So vaccines in this group can prevent these infectious diseases and also prevent recurrence of disease, which can actually make the malnutrition worse. So in the acute phase of the malnutrition, you want to consider the catch-up vaccines after addressing the issues of the malnutrition. Children on corticosteroids and other immunosuppressive drugs, the use of live vaccines in this group will also depend on the dose and duration of the steroids. If it's short-term use, then you can continue with the vaccinations. But if they've been on long-term use of the steroids or other immunosuppressive agents such as methotrexate, you may want to delay the vaccines for 3 months and then continue. And that principle applies also for the immunosuppressive therapy. Again, these are children we really need to discuss as a team and make a schedule for them. Children with bleeding disorders, have you come across children with hemophilia, type A, B, von Willebrand disease? Nobody has had to vaccinate a child with hemophilia. I also receive a lot of calls because they're like, okay, we have a child with hemophilia. What do we do? So some of the things we advise is one, when was their last prophylaxis treatment? So ideally, they should receive a prophylaxis treatment a day before they get the vaccination. That's one. Two, the type of needle you use. Please use the tiniest needle you can, and preferably use the subcutaneous route. Okay. Three, you want to apply pressure. Not just the little one you apply and then you put a tape. No, this one you stand there, you hold for at least minimum should be 2 minutes. Okay, but even so, this child might still form a hematoma, and you need to inform the caregiver that this can happen. All right. And we should ensure that these children with bleeding disorder are vaccinated for both hepatitis A and hepatitis B because they are recipients of receiving blood products, okay, such as cryoprecipitate in some settings. How about professional related exposure? We are all professionals, right? We are nurses in the clinical space. Do you need to be vaccinated against anything? Why? Because you are high risk of exposure. Exposure to what? To patients who are sick, whether it's body fluids, whether it's blood, whether it's the droplets, okay? So for healthcare workers, these are the recommendations that you should be able to receive these vaccines, the hepatitis B, the typhoid vaccine, the seasonal flu, and COVID-19. At that time, it was recommended. For emergency and essential workers, these are such as the armed forces, they also require the hepatitis B, the flu vaccine, and the COVID-19. For carers and caregivers, for the very reasons they're exposed to body fluids, to blood, to droplets, so they also require the hepatitis B, typhoid, varicella, the flu, and the COVID-19. Those who work with animals, the vets, so they're exposed to animals. And animals also, when you hear I've been scratched by an animal, what's the first thing you think about? Rabies. So they need rabies in addition to the tetanus and diphtheria. Industrial workers, these are workers who work in industries, different industries, in factories. They also require tetanus and diphtheria vaccine. And food handlers, I think all our food handlers need to be certified before they can be able to handle food in a commercial scale. So they require the cholera vaccine and the typhoid vaccine. So these are there's a table, a nice table in the 2023 Kenya National Immunization Policy Guidelines by the Ministry of Health, showing the type of vaccines the immunocompromised special interest groups require. And that includes the cancer patients, the HIV, the sickle cell, diabetes, and those with immunodeficiencies, elderly persons, travelers, persons with jiggers, and lastly, the trauma or circumcision. So that's just a table highlighting just mostly what I've talked about. Thank you for listening. Any questions or comments?
Any questions from the floor?
Any questions, any comments? Maybe you've understood everything or? Okay, great, thank you.
Okay, good afternoon.
Good afternoon.
So me, I have a questions on sickle cell. There are these patients maybe currently are residing in Nairobi, but maybe they come from Kisumu, which is a malaria endemic zone. So they have gotten all the 4 doses of malaria vaccine, but they are asking if they can continue with program.
That's a very good question. Yeah, so for the malaria vaccine, I think it has been rolled out in the malaria endemic areas, that's Western Nyanza. And we don't really vaccinate
Children who reside in Nairobi. So if this child has already received the vaccines, or even those children who are born in Nairobi and have not gotten the vaccine, Nairobi is not considered like a malaria endemic area. So even for those children who they migrate to Nairobi and they're on Proguanil, we actually stop. We stop the Proguanil and just sensitize on ITNs and the treated nets and just we treat as soon as we suspect malaria, but we don't put them on prophylaxis. Yeah.
Good afternoon, sorry.
Good afternoon.
We know so many adults coming for need vaccines in get roots. And we are doing vaccine. Is it okay? And is it now those before those
For the adults,
vaccine?
for the adults,
You mentioned one of the recommendations
yes.
for the special groups, also for those that maybe are away, splenectomy, stem cell surgeries. One of the recommendations is to give him, that is immobilized influenza B vaccine. And you realize for the pentavalent vaccine, according to WHO's recommendation, I think you can give the vaccine up to the age of 5 years because of the false hepatitis concept. So usually the recommendation is you can give an acellular hepatitis vaccine, and for hexaxin, it is more safe when it comes to know the reactions. However, according to affordability, because not everyone will afford hexaxin, more so in the public space, patients going to KNH and the rest of the public hospitals will be recommended to get the pentavalent. But if you are in a setup where hexaxin is available, in terms of safety, you can recommend hexaxin as opposed to pent. Okay?
Yeah, thank you for that. It actually makes sense. As I mentioned, Haemophilus influenza type B does not come as on its own as a standalone vaccine. It comes
as a combination. So I guess for those who require HIV, like even for sickle cell, we usually now we recommend the pentavalent at the 2 years and 5 years, or hexacin based on their recommendations.
Hope it's clear. Yes, we have so many people coming from all over the country. There is only for specific countries.
And why are
why are they being recommended and what are their conditions where they
And those special conditions.
okay?
So if people need to know, they can give pentavalent because they are coming all over from Turkana, from Vanessa, from Mary for him vaccine.
I think it's because of the safety profile of a cellular pertussis, and maybe that is why they are coming to that specifically, or maybe in a private setup. Because you realize for the whole cell pertussis, even you, maybe let's say for any child that you give the whole cell pertussis vaccine for 2 years, the reactions are quite bad. Okay, that is why we choose to give hexacin because of the safety profile. Okay, in terms of reactions.
So I've had a couple of patients, pregnant women who come in and the question is, when they're exposed to a child with chickenpox infection, what advice do we give them in terms of vaccination for someone who hasn't had any immunity from chickenpox, either from infection or vaccination prior to the pregnancy? So they're worried about exposure now, an older child who has chickenpox infection and the mom is pregnant. What kind of advice do we give them? Okay, yeah, that's quite a tough situation, especially if the child is yours and the mother. So your child is sick with chickenpox, you're the mother, but you're also pregnant. Okay, so what advice should we give them? It's the toughest of the advice, but isolation. You need to do some form of barrier nursing. You cannot give a live vaccine to a pregnant woman. And this also happens in our pediatric oncology wards. We talk about chickenpox outbreaks, we have them. And in a ward, we can have 10 children. One gets chickenpox, even as we are realizing the child has chickenpox and we are isolating the isolation rooms. And we would need to start
All those children in that room on some form of antiviral treatment, a cyclovir, because we cannot vaccinate these children because this is a live vaccine. So it's the toughest of advice, but isolation, barrier nursing. As regards taking prophylactic, maybe antiviral, I might not be sure about that.
And maybe, Doc, in addition, you can do, you can vaccinate around the baby, around whoever is undergoing treatment. Just vaccinate around them to just protect this vulnerable.
Sort of like creating a herd immunity. Okay.
So there's some online questions. Don't forget the online audience. They are around 560.
Okay.
And there's one question that was very, very interesting. Sorry, I've lost it again. So are there any new vaccines in the pipeline, or are there any new modalities of giving vaccines rather than injections? Maybe I heard this AI. So.
Yeah, thank you. Thank you for that question. It's a very interesting question. I don't think I might be the best person to answer that. I think we've talked about a few vaccines that are in the pipeline. Even from today's talk, there's the meningitis that is now going to be covering 5 serotypes instead of the quadrivalent. We usually have different influenza vaccines every year with different strains based on the surveillance of the previous year, the strains that were shown to be causing disease. So in terms of the route of administration, is it injections, oral? I think I might not have much information on that.
Okay.
Yeah.
I think we've heard of certain areas where they're going to start using intranasal. Yeah.
Mm.
So I think that would be a good way to start. There's still a big disparity between public and private vaccine and vaccination calendars. How can you comment on this? This is a tough question. Between private and public vaccination calendars, what can be done about this? It's a tough question.
Yeah, quite tough. I may not have all the answers to that. And I had shown the vaccination schedule for private and for government. Not much of disparity, really. And honestly, from a policy maker standpoint, we just have to rationalize the use of scarce resources, because you're looking at vaccinating a whole country, the children in a whole entire country. So the resources would be scarce. So you have to rationalize, of course, using the science, like what is killing our children. You saw how we introduced the pneumococcal based on compelling evidence that pneumonia was the #1 killer of children. So, and also rotavirus once it was introduced. And even now, as we are considering introduction of meningitis vaccines, it's based on the science and the evidence of what is killing our children and prioritizing and rationalizing on that. Yeah.
I don't know why you're getting tough questions. Will SHIF cover vaccination and the private? Who has read SHIF?
Yeah, those are very interesting questions. And I'm thinking,
Okay, even from a consumer, someone who's reading about, that transition of NHIF to SHIF. NHIF was covering vaccines before, and SHIF is going to be better than NHIF, as they say, isn't it? So it should be able to cover this vaccine. I will leave it at that, because the jury is still out there.
So thank you, Dr. Kathy. There's one last question.
Yes, Doc, I have a question for you.
Yes.
And in regards to the pneumococcal vaccine that you gave to the safeguard, I understand we have the pneumococcal, the PCV, which is conjugated, but according to the guidelines, you're supposed to boost from the second day of life with a polysaccharide vaccine. And so in this case, a pneumo 23 vaccine. However, in our market, we only have a PCV10, which is the pneumococcal conjugate vaccine that you give in the cases. And then in the private space, we have a PCV vaccine. Is it still okay to boost with the PCV vaccine from the second year of life, or is that another mistake to miss on this opportunity?
Good question. Thank you so much. And for experience, we do not have the PTSD 23 vaccine in the market. For some reason, it's not there anymore. Sanofi do something about that. So instead of just leaving the child exposed, we do recommend we write the PCV. They would rather get some form of vaccination, even what we have at the time available in the market. So PCV10 would cover 10 serotypes, while PCV13 covers 13 serotypes of the strep pneumo. So it's at least an added cover compared to PCV10. Thank you so much.
Hello. So, guys, I think she took us very slowly, and weirdly now she said 3 minutes, which is interesting. Between her and Dr. Mashani, we go for a marathon together. So I invite Florence Kamau, a very, 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 very good teacher on vector ecology and steward. Yes. So she'll take us through a bit of the best practices in vaccination, and please give her your undivided attention. And before that, she'll tell you how to stand up for like 2 seconds.
Good afternoon. I'm so excited this afternoon to be talking to my fans
And kindly, they know how we do it. Let's stand up. We need to boost our energy level. I don't intend to keep you here for long. I know I'm the one who starts doing between you and your lunch, but I will just keep you here for 2 hours. Then after that, we will break for lunch. So, Janet, you know how we do it. So let's boost our energy levels.
So let's stretch our backs. Hold the table, then go down. We do it 3 times. Okay. The last one.
You can have your seat. You can already tell how healthy you are. So I'll be taking you through vaccine best practices. So this is going to be a very interactive session because this is what we do every day of our work. So to achieve efficacy of vaccine, several measures have to be adhered to. And these measures start from the way we handle the vaccine, the way we administer those vaccines, the way we prepare them, and of course, how we do our documentation. How do we handle, where does our handling of vaccines start? Where does it start? I can't hear. Yes, our handling of vaccines starts from the manufacturers. What about the storage? Yeah, so the handling and the storage of vaccines is a very important factor to consider if we are to be able to eradicate the vaccine preventable diseases. The storage also determines whether those vaccines remain potent and they will accrue the benefit that they are intended to accrue when we administer the vaccines. If we don't handle and store the vaccines well, and we administer them to the client, it means the client might lose confidence with the vaccines, and the subsequent compliance will be compromised. So proper storage and handling of vaccine begins with an effective cold chain. Where does the cold chain start? Then after the manufacturer, where does it go? Pardon? When the vaccine leaves the manufacturer, how do they get to us? From the through distributor, ship, then to the Bell's facility, and then to the client. So that is the cold chain flow chart. It starts from the vaccine manufacturing, distribution, then they arrive at the provider, then at the provider level there is storage and handling, and then there is administration. Who is responsible for the cold chain at the manufacturer's level? Who is responsible? So where do we come in as the healthcare providers? Yes? At the storage and the administration. Because if we don't make sure the vaccine, when they come from the manufacturers, the distributors, the cold chain is maintained, but then when they get to us, we compromise, will they remain potent? So I don't think I need to explain that slide. I've already talked about it. The only thing I will say is the potency of vaccine is reduced every time we expose the vaccine to excess light, to cold, and to excess heat. So we need to make sure that we maintain the vaccines in the correct environment. Because once potency has been lost, it cannot be restored. So what are some of the parameters we use to ensure that our vaccine remain potent? What will be the guide? Yes, I had given you a more Kenya. Yes, the vaccine vial monitor is the guide that will help us whether the vaccine still remain potent. And we should ensure that we maintain our vaccines at a temperature of 2 to 8, okay? So when the VVM is at stage 1, what should be happening? Sorry. Yeah? The inner square is brighter than the outer circle, and that vaccine is good for use. When it is at stage 2, the inner square is slightly dark, but still brighter than the outer circle. When it is at level 3, it is the same color. The inner square is the same color with the outer circle. When it is at level or stage 4, the inner square is darker than the outer, than the outer circle. So at stage 3 and at stage 4, do we use or don't use? What if it has not expired or it has not reached its beyond use date? Do we use? We don't use. So the next thing we have to make sure when we are adhering to the best practice in vaccine is during vaccine preparation. We have to make sure that we are preparing the vaccine in a clean and safe environment, free from contamination. We have to ensure that the vaccines that we are preparing, they've not expired, or the beyond use date is still valid, and we have to make sure we are practicing hand hygiene. So let me ask a question here. You have a beyond date of 20th of June, and you have an expiry date of 30th of June. Which one will you follow? 20th of June as the beyond date used, and 30th of June as your expiry date. Which one will you use? Which one will you use? Are we sure? Which one will you use? Which one? 20th, yes. If you have a beyond use date, which is nearer than the expiry date, you use the beyond use date. You ignore the expiry date. And if you have an expiry date which is closer than the beyond use date, you follow which date? The expiry date. True. So you need to prepare the vaccine at the time of administration. We don't prepare them in advance to reduce. In the morning, there are no clients, so why don't I prepare 5 doses and keep them on standby? They will reduce the work for me. When the clients come, it's dunga and move on. We don't do that because that will compromise the cold chain, and it will also introduce the infection control will be compromised. I am administering PCV10. It is remaining a small amount in the vial. I withdraw and I realize it didn't require get to the required dose. I need to get another PCV10. How do I go about it? How do I go about it? Yes? I am not hearing, I'm hearing a lot of murmuring. Thank you. You don't mix the two. You discard the little that was remaining and withdraw from the new vial the dosage that you require. Then if you are administering more than one antigen, how do you know whether you're giving the pentavalent or the PCV10 once you've withdrawn them from the vials? You label. You need to label them because if you administer, which leg do we usually give the pentavalent? The left. So you need to make sure you've labeled them to know you've administered the pentavalent on the left and you've given the PCV on the right. Why do we do that? Is it important? I can hear people have learned big names, reactogenicity. I don't even want to explain. Because if this baby comes back, they have reacted, you will be able to isolate what they have reacted to. But if you just give whichever, it will be a guess. And then you will have a challenge in managing that patient or that child. Then, how long should we store the vaccine that we have withdrawn of the cold chain before administration? How long? Are we conscious about it? Should we be maintaining the cold chain when we have already withdrawn the vaccine ready for administration? No? I had a no. Oh, you had a yes, you indicated. Yes, even when we remove the vaccines from the virus, we still need to be conscious about maintaining the cold chain. So we should store them out of the cold chain within the shortest time possible. And then you're doing measles, you realized you can't find the diluent for measles. So what do we use? Water for injection, maybe? Yeah? What do we use? This child, you gave them an appointment to come for measles. They've showed up. You don't have a diluent for measles. And you can be sure this mother will not be very excited. So what do we use?
Currently in the market, we have two types of measles. One we use water for injection, the other one is monosalin. So you have to be very, very careful which one you have and what diluent you need. And in case you don't have the diluent, you have water for injection, it has to be at a temperature level, the same as the vaccine. So you have to keep it in the fridge to be
You had, she's talked as an authority in vaccines. Why are we doing all that? One of those number plates happens to be mine. So I just assume I have not seen. And we continue. So let's move on. Vaccine administration as the other best thing we need to consider. Just a minute. Thank you, thank you. So, vaccine administration. Before you administer the vaccine, you have to evaluate for contraindication. ensure infection control, and then adhere to the check your expiry date, the beyond use date, and of course, follow the 7 hours of vaccine administration, which you had enough time to take. Yeah? Which haraka, I told you I'm standing between you and your lunch. The first ask for vaccine administration.
Vaccination.
Yes. Continue. Yes.
Right vaccine.
Mhm.
Right dosage.
Mhm. Are we at 7? We at 4? Right documentation. Right documentation. The right size. The last one. The right route, the right needle, the right technique. Okay? So, why is it necessary to use the right needle? Why is it necessary? Daktari just talked about it. So I am expecting it to be on our fingertips. Why is it necessary? If you, yes, Derek.
Can think of two reasons.
Yes.
First, depending on the site in which you want to deliver the vaccine.
Yes.
If it's intramuscular, you might need a moment. And then for those with hemophilia, you need a small gauge to minimize any form of bleeding.
Thank you. So you need to follow up the safe vaccine practices. Ensure you use a sterile needle and a syringe. Discard the needle in case it gets into contact in the surfaces before use to prevent reintroducing infection. Ensure that you're preparing the injection in a clean environment, and let's ensure that you remove the needle if you are using the multi-dose vials. Don't leave the needle on the septum. It introduce infection. Skin preparation. Which products are we using to prepare the skin nowadays? Distilled water. Any other thing that we are using? Any other thing? Yeah. Spirits? Are we using spirits? Why are we not using spirit? I can see people nodding their heads through my heart. Why are you not using spirit? Why are we not using spirit? There is no right or wrong answer. Yeah. Yeah. We assume that the skin is clean, the skin of the baby is clean. By the time the mother is bringing the child, they had washed their child through all course. So even a dry swab is still sufficient to wipe the injection site and give the injection. We no longer use she talked about distilled water. We no longer use the swabs we used to dip in containers and we put cotton wool because of the risk of infection. If you choose to use the distilled water, it has to be in a pre-filled separate bottle that you will squeeze, remove the amount you want as per use. You can't have it already prepared, the swabs already prepared. Then you should never recap the needle, and that's why we are discouraging the use of, once you withdraw the vaccine in a multi-dose vial, we discourage change of needles, not unless it is damaged, to avoid also the risk of tapping and getting an acute injury. So how do you determine the needle that you want to use for administering? We have already answered that question, right? We talked of the route of administration, the age and the size of the patient, and of course, the injection technique that you're going to use. So I want us to have just a brief on the injection technique that you're going to use. So when we are doing an IM injection, at what angle do we introduce the needle? Which angle? At 90 degrees. So why 90 degrees? Which muscles are we targeting? Which muscle are we targeting? Which one? Why not at 30 degrees? Which muscles are we targeting? We introduce the needle at an angle of 90 degrees because we are targeting the muscle tissues. We don't use and also the size of the needle, because we want to make sure we deposit the vaccine where it is required. And that is just a photo. And which side of the vaccine, where do we give, which side? Which side? I am, when we are giving the DPT, yes? I can hear someone talking here. Yes, speak up. The upper outer quadrant. Yeah. Why choose the upper outer quadrant? David, why upper outer quadrant? Yeah.
I think you're reading that page to the button because the lower quadrant, the middle, towards the middle side.
To affect any nerve involvement. So when we are doing the subcutaneous injection, which side are we introducing the needle at what angle? At 45 degrees. Why 45 and not 90? Yeah. Yeah. Which are your target muscles? Yes. You're targeting the subcutaneous muscle. Thank you. So let's continue. When we are doing a subcutaneous injection, we said we introduce the needle at an angle of 45 because we are targeting the fatty tissue or the subcutaneous tissue. And that is how you encourage the mother to support the child if you are giving at the deltoid region, so that there is going to be minimal resistance and you will be able to administer the vaccine safely. Documentation. What do you usually say, nurses? What's our mantra? Not documented, not done. So why do we document the vaccine? Yes. We make sure we document So that even if that patient goes to another healthcare provider, they can be able to pick up from where we stopped. True? And also that is a very important record for the child. On top of that, in case of any reaction, you can be able to know the batch number of the vaccine you administered, the site of the injection, and it can be able to guide on the future follow-up. So make sure you document on the vaccine given, the dosage, the injection site, the route, the expiry date, the batch number, and the education you've given to the client. And of course, the date of return. And you make sure you document on all the requisite documents. We've already answered why document, right? So moving on swiftly, we'll transition to our next, but on summary, we've said vaccine best practices has to ensure we handle the vaccines well, we prepare them well, we administer them well, and then after we've done all that, we make the correct documentation. This has become our nice topic of the day. I think every other presenter who's talked before me has discussed vaccine hesitancy. I'm sure even if I sit, you can all be able to give a lecture on vaccine hesitancy. True or false? So why is it so close to the heart of all of us? It is because we are trying to increase the vaccination coverage, and we are also trying to make sure we reduce on childhood mortality, and we have a healthy nation. And in every community, there has to be individuals who will not trust vaccines. And we want to discuss how we can have them trust the vaccines as being safe. So as hesitant individuals, I want us to define how we will identify them, how to listen to them and their concerns, how we respond to their concerns helpfully, and then how do we move them from being hesitant to taking up vaccination. I think you've seen this somewhere else. So for hesitancy is a delay in acceptance or refusal of vaccines despite availability of vaccines. So we have category of those who will accept all. There are those who will accept, but they are not sure, one or two. Then we have those who will accept some, delay some, refuse some. We have those who will refuse, but they are not sure whether they should refuse or they should accept. And we have those who will refuse all. So factors contributing to vaccine hesitancy, we have complacency. There are those people who will say, you've always talked of polio, but in the whole of my lifetime, I've never seen somebody with polio. So why should I prioritize giving vaccine against polio when I have other life and health priorities that I can consider? We'll have low confidence, others who have confidence with the system, with the vaccine, with the provider. Then we have convenience also as a factor, availability, accessibility, affordability as some of the conveniences that may affect or contribute to hesitancy. So we look at the factors influencing decisions about vaccination. Some of these factors are contextual, like the media. You all had some years back, about when the 5 doses of tetanus toxoid were introduced to pregnant mothers. You all had the debate, eh? It was so popular in our press, in our media. The local politics, when our politicians stand and say, this is not for the good of our population, you cannot tell how that conversation will go. The religious leaders, when HPV was being introduced, there was a very heated debate about it being given to our young girls by our religious leaders and some of our cultures also. And that greatly affected the uptake of HPV, which we are still struggling with even today. Because once words have come out of the mouth, you cannot recall them. It will take you double effort to undo what those words have already done. Accessibility of service. We've been having shortage of vaccine recently. You've seen mothers walking for so many kilometers to go look for the vaccine. When they don't get it, do you think they will be planning that trip anytime soon? So that again will affect the trust in authorities. Can you be trusted? Do you can we trust our government with vaccines? Don't quote me. I didn't say it. Individual and group influences, beliefs and attitudes. There are those people who believe vaccines have got no role. Even our great-grandparents never got vaccines and they lived. Before you can undo that belief, it leads you to redouble the effort. Knowledge and awareness. We have those people who don't even know the benefits of those vaccines. So that will resort to hesitance, but it is as a result of ignorance. Then the poor quality health services experience. A client has come, they've not gotten a good experience. They decide it's not important. After all, even me, I got up to measles and I am still alive. So it can end there. But if you gave them a pleasant experience, you'd give them a reason to come back. Vaccine and vaccine-specific issues. The mode of administration, we just had it. Someone asking whether there is any hope of us having vaccines that are not an injection. Majority of the people fear injections, right? So if you to make them to keep coming, you have to make that experience pleasant. You have to give them a reason to keep coming. There are some people who believe these vaccines, where they are being sourced, we are not in the first place even sure they are vaccines. They could be anything else that is packaged to harm us and our children. The vaccination schedule. My past presenters have said there is that I don't know whether it's Dr. Anne who said there is that client who they just give one vaccine every month and she's perceiving they might finish the schedule in 2 years. You have to keep encouraging because the bottom line is to make sure that this child gets vaccinated, whatever the case. Then the cost associated with vaccination, we've all here said vaccines are not cheap, but which is easier, to vaccinate or to manage the disease or to lose the child? So it is a balance. The knowledge and attitude of the healthcare provider. how you interact with that patient or that parent or that caregiver determines whether they will be enthusiastic to come back. They might just say it's not worthwhile. That provider was so rude, looked disinterested. I am not even sure they gave my child the right vaccine. And when it gets there, you lose that client. So how do we express hesitance? You will be asked about the risk, about providing the vaccine to the child. You will be asked whether the child is going to get sick after vaccination. You will be asked whether the vaccine is necessary. You will be asked whether the vaccine is safe. So kindly take a minute and tell your neighbor any vaccine hesitancy, say statement that you've had. The people who are online can wait for us. We need to kindly share in the table and they give us one of the vaccine hesitancy statements that they have had. So let them just fill in the table, then we proceed. One, and we move on. So we had several vaccine hesitancy statements, and you know them all. Senior, you've had several of them. Will my child die after the vaccination? Is this very, very necessary? So who are the people who might show hesitance? Yeah, who? The caregivers, yeah? The expectant mothers. Can healthcare providers be a source of hesitancy? Can we be a source of hesitancy? So we can, eh? Then that is serious. And we are the people who are supposed to be the influencers and the advocates. So when we saw hesitancy, then it is catastrophic. Because who will preach this gospel of vaccines? That's why we are here, so that we can be able to be influencers. So all those categories of people can express hesitance. So how can a healthcare worker identify a hesitant individual? You need to open the conversation with a presumptive statement. Today, Dr. Jane, you're supposed to be getting a meningococcal vaccine. Okay? I am talking from a position of authority and a position of knowing, not asking you today, Dr. Jane, what are we going to be giving you? We are giving you room to decline or to accept. But when we talk from a position of authority, we are opening it up for a conversation. So, examples of some of the responses you will get from this hesitant category. Those who accept all, they will tell you, I am ready. Those who are accepting but not sure, they will tell you, okay, I guess I will vaccinate. Those who are accepting some, delaying some, and refusing others, those who are refusing but they are not sure, they will be telling, I don't know, I have doubts. Others are, no, I'm not sure this is right for my child or no, for me. Those who are refusing all, they will tell you, I don't trust the vaccines. Then, so how do you proceed? Those who accept all, you'll vaccinate and reinforce and strengthen and encourage. Those who are hesitant, you will use a guided motivational interviewing method to engage. Those who are refusing all, you don't dismiss, you read a piece, you're like, ulikuja kufanya nini? Don't have a debate, focus on their concerns. Leave space for a discussion. You can also offer to refer to a more senior health professional. Can I book you an appointment with a pediatrician who can have a conversation with you? Or give them materials to go read, then thank them for even making the effort to come and give them another appointment. Or can also share with them the signs and the symptoms of the disease because they are in the community. They might decline to get that MMR, and then in the neighborhood, there is a child with measles. So you need to give them at least signs and symptoms of a child who is suffering from measles, so that if they see it, they will know, I need to seek care. So let's just explore. This is where our interest will be this afternoon. How to hack this motivational interviewing technique. It is a method of interacting with patients and with the name of exploring hesitancy, reasons for hesitancy, and changing attitude and behavior. It is collaborative, it is patient-centered, with an objective of hitting the bull's eye. And the bull's eye here is making sure we vaccinate, okay? So our effort in all this will be to move the caregiver from being hesitant to accepting all the vaccines. So how do we address this vaccine hesitant? You will, as I had earlier indicated, we'll use the motivational interviewing technique. And this will use open-ended questions and ask what, why, how, tell me, to get to understand which are the concerns of the client. You reflect and respond and acknowledge their concerns. Then you also address the concerns and educate on the benefits of the vaccine, the side effects, and the number of doses to be administered, the site of the injection. Then you administer the vaccine if accepted, and schedule for follow-up if declined, and of course, thank the client. Whether they get the vaccine or they don't, thank them. They took time to come. I want to give an example of the motivational interviewing technique. A mother has come with an 18-month-old baby. We know at 18 months, this baby is supposed to be getting the data and the MMR already. But the mother tells you, this was echoed by one of us here, that I am not going to get the measles vaccine because I have learned it causes autism. How do you continue from that? You will acknowledge the concern of the client that you had. They've said they will get the data, but they will not get the measles vaccine because it causes autism. Then the next step, you'll ask the client permission to tell them what you know about the MMR vaccine. Acknowledge. See, we all have had MMR causes autism. See, hata tumesema hapa. You'll tell them even you've heard about it. But there are expansive research studies which have been done, and it has proven not to be true. And you'll also tell the client the MMR vaccine is safe, and you'll also tell them if they don't give the MMR vaccines, the child is likely to get the disease. If they get the measles, how it is going to present, then it is a fatal disease if it is not treated in good time. You also let the client know the cost implications of giving MMR vis-a-vis managing the measles. Hello? Are we following through? So you will provide information to change the parent or the caregiver's perspective. And that's what we have been discussing. But make sure you avoid arguing and focus on the disease prevention. Tumesema autism. Hiyo ulisikia wapi? Is there anything to support it? That's just a myth. Don't be abrasive. Engage in a professional way. Share the knowledge because you're the authority. The client will have Googled in some authenticated sources and they have told them MMR causes autism. It is you as the caregiver who has the right information. Disseminate that correct information. So after that, you will still make a personalized recommendation to vaccinate that day. I feel we should vaccinate David, the MMR vaccine. Then you let the client make an informed decision. If the client still remains hesitant, you will thank them, offer them additional materials to learn, and give them the next appointment, or book them an appointment with a more superior person who can discuss further with them. So this is just a summary of step-by-step overview of how to use motivational interviewing technique. We said you'll start from a presumptive statement. We are going to vaccinate David MMR today. You ask open-ended questions, you reflect and respond, you affirm strengths and validate concerns, you ask and provide and verify, ask questions, probe more. Maybe this client is even telling you that they've had the child has autism, it gives us, it gets, MMR causes autism, but maybe because the child's neighbor has autism, which was diagnosed around the same time they were given MMR. Sawa. Then summarize and describe action. So let's vaccinate to protect. Thank you. Any question? Any verification?
Guys, give a proper answer. You know, when you're the last presenter and people are still like,
You're blessed. Eh? So thanks for really giving us a. She attends most of our sessions. So today she's the teacher, right? So before we continue the question, what is the greatest invention in medicine? Which is the greatest invention in medicine? Hmm? Yes. No, not the section. Vaccines. Let's be specific. The greatest invention in medicine is doing Julius. No, not pharma company, but thank you. Which is the greatest invention in medicine? Prevention. Prevention? Okay. Which is the greatest invention? A doctor. The greatest invention in medicine is? Again, the greatest invention. Don't forget it. Yeah? You say this in church. Eh?
before we should, the greatest invention in medicine is eradication of smallpox.
Okay, that's good.
You can Google it if you don't trust me. It's an invention. Yes. Because it showed that diseases can actually be eradicated. Yeah? So eradication is an invention, right? So guys, remember, some of these diseases are here with us and we need to eradicate them. We have 2 or 3 questions. There's one that was specific about men B. This one, I think we had it in the last session, and we noted that men B was given separately because of the idea that the studies were showing it gets immunogenicity when it is, of course, coupled with the other antigen, right? There's another question that came about on tetanus and diphtheria, why they are given together. I think we can answer some of these questions now. You know, these are masterclass. Eh? When you live here, you are masters in vaccination. So why do we give diphtheria and tetanus together? Anyone to answer? You know, we're answering online too. Right? Why do we do that?
Why do we give a DPT in one combination? I think we've started not all our presentation. Who can tell us why we have all antigens under one file? Anyone?
Quickly, lunch is getting cold. Wilfred, answer for them.
So one of the reasons why we are doing all combined vaccines under one vial is because we also want to reduce the number of cells we're giving, right? Remember in the primary immunization, you have how many vaccines to prevent? You have 6 early childhood infections. We have our pneumococcal vaccine that you're giving, which comes as an injection, of course, apart from oral polio and the rotamid is given orally. So you can imagine if you're giving your DPT, the diphtheria separate as a standalone, tetanus as a standalone, and the pertussis as a standalone, it will be chaotic, So that is why we have a benefit of having all combined vaccines, basically under one vial. Okay, to just minimize the number of jabs that we give.
This question, what is the difference between immunogenicity and reactogenicity?
Again.
Tafadhali, do we know the difference? Yes, so the difference is simple. One is the immune ability to the antigen ability to generate an immune response, and the other one is, of course, the reactions due to an antigen, right? Introduced. There's another question which is political, or what's the difference between one is friendly to the baby, one is friendly to KP. Difference between KP and baby friendly. And then we'll have our last question. Someone has asked Dr. Mashara, she can be thinking about it. This concern about playing again this thing of diphtheria vaccine. Someone has really insistent. Sorry, pertussis vaccine. Please explain. They even called my name, Dr. Amai, in front of everyone.
What do they want to explain?
Please explain. Pertussis do a booster dose to individuals above 5 years. Yeah. So you can explain this one by then.
Okay, so as we have seen resurgences of pertussis infections, not just here, but even in Europe, in US, so that brought about interest in how long do these antibodies last. And that's when the data came out that they last about 10 years. So that's why those children who are aged around 8 years to 15 years were the ones who are coming primarily with disease. And then when they are infected, it means that the children who have not yet reached the 6-week mark are also vulnerable because you have better cells circulating in the community. So boosters should be given at 10 years as well, yeah, and then to the older population. But like I told you, there was even some data around giving it every 10 years if you really want to eradicate, because then I was in my 40s, so as a healthcare worker who was immunized that long ago, and you're coming into contact with those children, there was that realization that even we are not carrying at a certain age enough protective antibodies. So all of this data has generated interest around what we're now calling immunization through the life course. So recognizing that immunization is not just for young children, and depending on how wealthy a country is, you can decide who are you targeting. So for example, we may not necessarily immunize young adults, but we need to seriously think about immunizing, say, our over 60 population. Thank you.
There's one question for Dr. Kathy. After a splenectomy, how early do you begin vaccination? Now, this is a very interesting, we get a lot of this question that someone has undergone, whether it's traumatic splenectomy after an accident or what. So when do we start vaccinating these guys?
Thank you for that question. Very interesting question. So even as you're thinking about doing a splenectomy, okay, let's leave the traumatic spleens where they have to come out immediately. We're talking about planning for splenectomy. So there are some important considerations you have to think about, because now you render this person immunosuppressed and it's a lifelong thing. So one, you want to vaccinate before the splenectomy. So you want to ensure this child has received all their booster vaccines, and then that is when you can consider performing this splenectomy. So these are the children who perhaps have overactive spleens. We see that even in sickle cell disease, we see hypersplenism, whereby this spleen is causing a lot of cytopenias, low blood anemia, HB, and also the platelets are low. So you get thrombocytopenia, and they require multiple blood transfusions. So those are hypersplenism. Those are some of the considerations to think about. You vaccinate before the splenectomy, and these are children who will be on some form of prophylactic antibiotics lifelong. So routinely we put them on penicillin B for life. Thank you.
Thank you so much, Doc. There's a last question for Dr. Mate. And what is the immunization schedule for a 2-year-old who has just moved from Uganda to Kenya and hasn't received any immunization since delivery? The patient is currently in Kenya.
2-year-old moved from Uganda to Kenya.
And has no history of immunization.
Has not received any history of immunization. So these are the patients now we schedule for catch-up vaccinations. So we actually do now a schedule for them, starting even from the BCG vaccine. So now, ideally, for most vaccines, you want to wait about 4 weeks between vaccination. So you do a catch-up schedule for them, starting from the BCG vaccine, and then every month from there, you schedule now a catch-up vaccine for them.
Can I just add something to that? For the child who is not immunized, for example, if you get them at 2 years, something like the measles vaccine is very important. So you may decide to give measles plus that pentavalent plus PCV, because you can give multiple antigens together. So I think the one I just wanted to emphasize is that measles needs to come early, because those are some of the life-threatening illnesses, whereas you're delaying, you can't do it quite like a child who is presenting early and still has protective maternal antibodies. You need to make sure all the important antigens are captured early. So in one sitting, that child really needs to get almost everything that they're able to tolerate. Yeah, you can give them measles, The Penta, the MMR, the PCV, rota we don't give to older children, but then you'll schedule it that way and explain to the parent why they may be receiving more than the normal number of injections because of the risk that they are already having. Yeah.
I think this ties in with another question someone has asked. Is there such a concept as over-vaccination?
So that question comes from mothers. You know, first of all, when they hear hexas do their 6 antigens, they're like, what? How will the body handle all of this? But I think over time and with experience, you've learned that the immune system is very capable of handling several different antigens and still mounting an adequate immune response for those different antigens that it has been presented with. So it is more that the way you have planned it, you don't want to give too much trauma, say for this child who's having catch-up, but in terms of number of antigens, I think that should not be a concern. What I'd say about live vaccines is that spacing is very important because you don't get as good a take if you're not strictly adhering to at least an interval of about 4 weeks. But I think number of antigens rarely is that a concern. So because you can give on one thigh, you can still give on the other. So with adequate spacing between the jabs, and maybe just something to manage pain, but managing the parents' expectations as well. So reassure them.
The last question of the day will be taken by Florence. And this one, I'm coupling it with like 5 other questions. I don't know why these questions are being asked, but since they're being asked, let's just make sure that we capture them. There are around 5. Like someone is asking, I accidentally gave the jab in the wrong place. I've had a case of giving an oral injectable instead of an oral, you know. So what do I do? I think it's a very pertinent question. One of the reasons why it's a pertinent question is that when we receive a lot of these PV complaints, as Sanofi, we have to forward them, right? And one of the problems that comes about is people will say, your vaccines are bad. They reacted with my baby. But when we do an investigation, we find that really the mode of administration was wrong to begin with, yeah? So how can we help healthcare professionals? I know Gertrude sees a lot of kids. Maybe there are places where they don't see enough kids. Maybe there's someone who has been moved from surgery na nadunga watu wazee na nini alafu naletwa kudunga katoi. So what do we do? How can we help the system avoid such errors in medication?
Thanks for that question. When you administer the vaccine using the wrong rate, the right thing is to admit as fast as you know you've used the wrong route, inform the parent, and also have that child followed up in case of any side effects that may arise from administering that vaccine using the wrong route, and also know that that child is not vaccinated. For example, I know when the rotavirus came, we used to withdraw it with a syringe and a needle. And many babies got rotavirus as an injection. So that child was not immunized because the uptake of vaccine or the efficacy of the vaccine will only be accrued when you use the right route. So the child needs to be vaccinated again using the correct route.
Is that clear? Me, I'm not going to vaccinate any baby. So you guys, is that clear? Yes, we only deal with adults, sorry, diabetes, hypertension. So guys, again, we're going to close it up. Thank you so much for attending this session. The questions were many. We managed around 86 questions. Actually not 86, that's 86 plus 58. That's a lot. That's a lot of questions. So thank you so much. I want to, before we close up, Julius, where are you going? We are introducing the team. Okay. So I want to introduce my vaccination team before we close, and then we can have a nice Saturday. Sorry for keeping guys waiting for so long, but I think we learned quite an immense amount of knowledge today. So Winfred, Julius, Cynthia, Come. Okay. So they'll just introduce themselves as we close up, right?
Yes, good afternoon, everyone. Yes, my name is Winfred Wamoshe. I am a vaccines representative from Sanofi. We now work under Group Ethica, the new part of Sanofi after closure in 2021. And I cover, we cover regions, right? So I cover Parkland, Mpisha, and Avenue, and then all the way to Eastland. So I'll give the opportunity to the rest of the team.
Good afternoon, everyone. My name is Cynthia Raymond. I'm a vaccines rep. I cover Parkland and Thika Road. And this was a very engaging session. I've learned a lot as well. And yeah, just over to my colleague.
Good afternoon. I'm Julius Ocheng, a vaccines rep from Sanofi. I cover parts of Nairobi South, Karen, Nairobi West, KNH. Yeah, those are my regions. For the sake of Gatri is also Pangani and Syokimau. Thank you for your attendance.
So this by no means is the whole team. This is like half the team. The others are another engagement. So thank you guys for attending. If you have any questions, PV related, how to train, please contact them, right? Contact them, right? Yes, don't inject or give oral injection and do it. So thank you guys for attending again. And I'm Dr. Amaya, your host for today under Sanofi and Ethica. See you on the next one.